development, making it your best choice to begin taking steps toward realizing your big dreams. Universitas Yarsi offers 16 programs across 6 faculties, including medicine, dentistry, law, economics and business, information technology, psychology, and a graduate school, where the Faculty of Medicine ranks among the top private medical faculties in Indonesia. The best national and international curricula are comprehensively applied in each study program to create qualified and professional graduates who can serve as community leaders, decision makers, communicators, care providers, and entrepreneurs based on Islamic principles. Students at the Faculty of Medicine set out on a mission to heal the world. Supported by state-of-the-art laboratories and dedicated mentors, they cultivate their dreams of becoming life-saving heroes. At the Faculty of Dentistry, we believe that smiles are powerful. Here, the students learn how to spread healthy smiles to the world. The Faculty of Law is where justice becomes a reality. The students learn how to be committed advocates who uphold the principles of justice. The Faculty of Economics and Business educates students on creating successful firms and developing future leaders. The Faculty of Information Technology is where codes are transformed into innovations. The air is filled with a spirit of curiosity and innovation, making the impossible possible. The Faculty of Psychology is a window to the mind and soul, where students learn how to understand and help others. The graduate school is where in-depth research and new discoveries happen. This is where future scientists hone their expertise. As one of the best private universities in Indonesia, nationally accredited and internationally well-known, we've earned the distinction of being the 3rd-ranked higher education institution in Jakarta for our impact on the Sustainable Development Goals, giving you the experience to be part of a global collaboration with various partners and universities on a national and international level. Universitas Yarsi is a place where education, research, and community development as the main pillars of higher education are upheld and carried out, encouraging you to be a smart, active, and inventive young intellectual with a strong sense of problem-solving and empathy. A place where art, technological innovation, culture, and diversity come together with Islamic values in a way that inspires and opens new windows to the world. A place where modernization, driven by the rapid advancement of the educational sector and technology, who are ready to rebuild the glory of Islam and make Indonesia advanced and strong. Here at Universitas Yarsi, the smart campus that
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, distinguished guests, and esteemed participants, we will soon begin the workshop of today's event on the first International Symposium of Genomic Clinic. We would like to ask if you can move forward and fill up the 2 tables at the front. Also for our speakers. Welcome to the workshop day of the first International Symposium on Medical Genetics Update from Genomic to Clinic, hosted by Universitas Yarsi. Today's workshop will be the first part of our 3-day event on medical genetics, and we hope to inspire you to embark on a journey of exploration and collaboration in the ever-evolving landscape of medical genetics. My name is Rahajeng Tujung Putri. I'm a genetic counselor and internal medicine specialist, and I will be your MC and take you through the programs the coming days. First and foremost, I'd like to extend my welcome to our esteemed professors and guest speakers. and experts today that we already have this morning. First and foremost, Professor Dr. Chandra Yoga Aditama from Universitas Yarsi, Dr. Wanedra Spesialis Anak from Universitas Yarsi, Dr. Aziati Azwari Anwar from the Human Genome Center, University Science Malaysia, Professor Dr. Sultana M. Farads from Universitas Yarsi, Dr. Seung-woo Ryu from 3 Billion Inc. Seoul, Korea, Professor Dr. Sofia Mubarika from Universitas Gajah Mada, Professor Zilfalil Alwi from University Science Malaysia, Professor Dr. Narazah Muhammad Yusuf, Advanced Medical and Dental Institute, University Science Malaysia, Dr. Anggraini Iriani, Spesialis PK from Universitas Yarsi. Our workshop will bring an excellent lineup of experts and guest professors, and we hope that you will participate interactively in today's workshop. The sessions today will be, the first one is tips and tricks on chromosome and molecular analysis of genetic diseases. Second session will be exploring genetic counseling practices, followed by lunch and prayer break. May today's workshop encourage us to share and improve our knowledge and interactively explore medical genetics. I'd also like to remind all participants to turn off your mobile phones or put it to silent mode to ensure that we have the best session possible. And we will start today's workshop with a prayer led by Mr. Afrizal, LC, MA, PhD. To Bapak Afrizal.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Untuk menambah keberkahan acara kita pada hari ini, marilah sama-sama kita tundukkan hati dan pikiran kita kepada Allah Subhanahu wa taala, agar Allah Subhanahu wa taala memberikan keberkahan dan kemudahan pada acara kita hari ini, dan Allah memberikan kemudahan baik itu di dunia maupun di akhirat. Ala hadhihi niyyah wa likulli niyatin salihah. Al-Fatihah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين حمدا يوافي نعمه ويكافئ مزيده يا ربنا لك الحمد كما ينبغي لجلال وجهك الكريم وعظيم سلطانك اللهم صل على سيدنا محمد وعلى آله وصحبه وسلم اللهم اغفر لنا ذنوبنا وذنوب والدينا وارحمهم كما ربونا صغارا ولجميع المؤمنين والمؤمنات والمسلمين والمسلمات الأحياء منهم والأموات إنك أنت سميع قريب مجيب دعوة ويا قاضي الحاجات اللهم إنا نعوذ بك من علوم لا تنفع ومن قلوب لا تخشع ومن نفوس لا تشبع ومن دعوة لا يستجاب لها يا أرحم الراحمين اللهم إنا نعوذ بك من عذاب القبر ومن عذاب النار ومن فتنة المحيا والممات ومن فتنة المسيح الدجال اللهم ارزقنا فهم النبيين وحفظ المرسلين وإلهام الملائكة المقربين يا رب العالمين اللهم يسر لنا أمورنا واشرح لنا صدورنا ولا تجعل للضيق مكانا في صدورنا يا رب العالمين اللهم اجعل جمعنا هذا جمعا مرحوما وتفرقنا من بعده تفرقا معصوما ولا تجعل فينا ولا معنا ولا من يتبعنا شقيا ولا مترودا ولا محروما ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكونن من الخاسرين ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين والسلام عليكم ورحمة الله وبركاته.
Thank you to Bapak Afrizal. Next, we will hear the national anthem, Indonesia Raya, followed by Marsiarsi. I invite you to stand up during the song. Thank you. The participants and speakers may take your seat. Next, we will have the Director of Postgraduate School, Universitas Yarsi, Professor Dr. Chandra Yoga Aditama, to give a welcome speech for our speakers and participants. Prof. Chandra.
Assalamualaikum warahmatullahi wabarakatuh. I don't know whether I have to speak in English or Melayu. Everybody can understand anyway. So first of all, on behalf of the Yarsi University, I would like to welcome all of you to the Universitas Yarsi. This is the 12th floor of the university, and in this floor we have several auditoriums and meeting rooms. This is kind of advertisement if you want to use the auditorium anyway. So in Universitas CRC, we have 6 faculty and 1 school of postgraduate, as mentioned already. I know in most of the country we call it graduate school, but here in ERC we call it postgraduate school. So in the postgraduate school we have 5 program now: Master of Hospital Administration, Master of Management, Master of Notariat, and Biomedical Science Master, as well as doctoral program. So several months ago, I just talked to Prof. Sultana, maybe 3 or 4 months ago. My colleague from the Biomedical Science Master Program came to me. And they have an idea to initiate an international meeting. At that time, we do not know whether it is a symposium or workshop, but there's some international. Thanks for Prof. Sultana, who have widely, renowned in this area. We have a network. So after that, we make some discussion, and then we saw this is a good idea, and we are trying to have more, a real international session. So after the program is more or less more concrete, then we report to our rector. I know in Malaysia you call it chancellor, as well as the chair of the foundation, and everybody agree. So Alhamdulillah, here we are for the opening of the workshop. So we are shukr Alhamdulillah for the all of hard work done by my colleagues. So today we will have the workshop, and you know that tomorrow we'll have the international symposium. I was informed that there are more than 60 participants. It was 63 this morning, but look at the room. I'm sure it's more than 63. Some are on-site registration, so it's good to have so many participants. And we will have 4 workshop session, to have this fruitful discussion and session and workshop, we are very fortunate to have 11, I don't know whether it is speaker or facilitator, but anyway, there are 11 experts who will here with us the whole day for this workshop, and 4 of the speaker or facilitator are 3 or 4 are from USM, University Science Malaysia. Is that correct? So please make applause for our colleagues. And we will also have one facilitator from the Republic of Korea, maybe not yet here. And I also welcome my colleague from Universitas Gadjah Mada, and from Rumah Sakit Anak Bersalin Harapan Kita. I don't know the English terminology, maybe maternal hospital, something like that, of Harapan Kita. And the remaining speakers are from ERC University. So by those, various facilitator, I do hope that we'll have a fruitful workshop. All of you will gain new insight, new knowledge, and sharing experience. And I do hope this workshop, as well as the International Symposium tomorrow, will be a successful event for all of us. So, on behalf of all of you, with Bismillahirrahmanirrahim, today I declare the workshop on medical genetic update from genomic to clinic officially open. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
I would like to invite all guest speakers to the front so that we can have a group picture. Please move forward. And we will have you face the front of the stage so that we can take the participant as the background. Excuse me, maybe, sorry, we will take another picture with the committee this time, with the organizing committee.
Udah silakan.
Thank you to our speakers and participants. So next we will come to the main event of today's workshop. We will start the academic session of this workshop. And for the first session, we will have tips and tricks on chromosome and molecular analysis on genetic disease. I would like to introduce to the participants our moderator for this session. We will have Dr. Wanedra, spesialis anak. She is a lecturer at the Department of Pediatrics, Faculty of Medicine, Universitas Yarsi from 2007 until now. She's also a pediatrician in Yarsi Hospital, and her research area and focus is in nutrition and children's growth and development. To Dr. Wanedra, I give you the stage.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah Rabbil Alamin. Good morning, everyone. Respectable the chair of Yarsi Foundation. Maybe sometimes he will come here and maybe they looked at the video. Professor Jonal Sudin, the chair of Yarsi Foundation, also rector, but now here Dr. Wading Sari, and Prof. Chandra Yoga Haditama, director of Magister Yarsi University, and the dean, our dean here, and honorable all the speakers of the workshop and all participants. Ladies and gentlemen, I'm Dr. Wanedra, the moderator of today's workshop session 1. I'm very pleased to see you here. Welcome all to you to this workshop. Today's workshop is about tricks on chromosomal and molecular analysis and genetic diseases. Our speaker today in the first session is Dr. Aziati Azwari Anwar from University of Science of Malaysia, and my professor, Prof. Sultana from Yarsi University. Before the presentation begin, let me inform how the presentation will going on. First, we'll be invite the present to present the material. After that, there will be question and answer session, and followed by the conclusion. The time for the speaker only 20 minutes. Okay, for the first speaker, Dr. Aziati Azwari Anwar. She has received Let's see the CV, Dr. Aziati. She has received the bachelor degree in medical at University Kebangsaan Malaysia and taken his master pathology in medical genetic and USM also. Her current opinion, genetic pathologist and medical lecturer, Human Genomic Center, School of Medicine, Science, Health Campus, University Science, Malaysia. Her topic today, analysis and clinical application of human chromosome and cytogenetics in medicine. Now, allow me to welcome the speakers. Please, Dr. Aziati, to deliver your presentation. The floor is yours.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everyone. First of all, thank you so much, Dr. Nedra, for a very kind introduction. And also, I would like to thank to the committee members of this first international symposium and workshop for inviting me to join this symposium and workshop. Okay, without further ado, sorry for the technical. The topic for today's discussion is analysis and clinical application of human chromosome and cytogenetics in medicine. You can raise up your hand if you don't understand what I am speaking, okay? All right. A little bit about the history of a chromosome. It is actually started back in 1878, where at that time, this Germanist biologist called Walter Fleming, he found a thread-like structure in the nucleus of the chromosome. And at that time, he named that structure as a chromatin, means a colored body. Later, it was given a different name, which is chromosome, by another German anatomist. And then, since then, there are a lot of study done to see and to study of the chromosomes. And this Indonesian-born cytogeneticist named Jo Hin Tio, he's the one who actually found that the number of chromosomes was actually 46. Before that, they thought that the number of chromosomes was actually ranging from 23 to 30s. So in 1955, after he found that the correct number of chromosomes, since then the development of the cytogenetics become bigger, all right? And then in 1956, they first noted that trisomy 21 is associated with Down syndrome, and then trisomy 13 is associated with Patau, and 18 associated with Edwards syndrome. And back in 1960, there is a big history in the cancer cytogenetics, because Peter Nowell finally found that actually the Philadelphia chromosome, which is associated with CML, chronic myeloid leukemia, is actually due to translocation of chromosome 9 and 22. So this is the beginning of the cancer cytogenetics. So what is chromosome? Anyone? Okay, chromosome is vehicles of the genes, because we know that in our body we have around 20,000 genes, and it is scattered in our chromosomes in the 46 chromosomes, right? So for your information, to study the chromosome, we need to see the chromosome at metaphase stage of the division, because at this stage we can see the chromosome very clearly and as a rod structure. During this stage also, we can see there's a constriction called a centromere here. So the chromosome above this centromere is called P-arm or petit arm, and below this centromere is called a long arm or Q-arm. Okay, Human has 46 chromosomes. As you can see here, we have 46 chromosomes, and half of the chromosome, which is from chromosome 1, 2, 3, and half of the chromosome actually was contributed by our parent, one from paternal and one from maternal. So the first 22 pairs is called autosomal chromosome, and the rest, the last 23rd pair is a sex chromosome. This is for male XY, and then for female is XX. Slide is not moving. Sorry. So for female, it is XX. All right. Now, what is cytogenetics? It is a study of human chromosome to determine is there any abnormality in the chromosomes. So the abnormality can be due to the abnormality in the number of chromosomes, or we call it aneuploidy, or any abnormality in the structure of the chromosomes. There are three ways to see the chromosomes. Number one is karyotyping, and then fluorescence in situ hybridization of fish, and chromosomal microarray. But for this workshop, we only focus on karyotyping. These are the basic steps of conventional cytogenetic analysis. So the analysis is actually not easy, and it has tedious steps involved. Number one is a culture. So we need a sample. We have few types of sample. Basically, there are is any kind of sample with nucleus inside. For example, we have blood, bone marrow, or in prenatal we have amniotic fluid. So this sample we will add with special media and culture in the special incubator in a special time, depend on the type of the samples. And then this is a critical area that we need to take care of, because we only can see the chromosome at metaphase stage. During metaphase, the chromosome is condensed so that we can examine the chromosome clearly. And then proceed with harvesting, slide making and staining. Only after we have the slide of the chromosome, we can examine the chromosome under the microscope. So this is one of our technologies, is examining the chromosomes. You can see here, these are how they look under the microscope. The one with the rod-like structure is the one with what we call in metaphase stage. So only these cells will be captured and further analyzed. So by using a special software, actually we can analyze more chromosomes. We can zoom the chromosome, and we can remove all the dirts and start to analyze of the chromosome thoroughly. So by using this software, we can actually arrange the chromosome based on the size of the chromosomes, and based on the length of the chromosome, based on the bending pattern. So based on this, we can compare the normal chromosome with the patient's chromosome and try to detect is there any abnormality, all right? And the analysis of the chromosome, we use a special system. One world is talking the same language. So we use this called ISCN, International System for Human Cytogenomic Nomenclature. The latest one is ISCN 2024. So this is the book that we are using. Then how to write the findings of the chromosome that we analyze. First, we need to put the total number of chromosome, followed by the sex chromosome, either XX or XY. But if there's any abnormalities, for example, when you see there's loss of X, so we just put 40X, 45X, something like that. And then write the abnormalities accordingly if present. For example, if normal condition in male patient, we just put 46, number of chromosome, normal one is 46, followed by the sex chromosome, and no abnormality detected, so we don't have to put anything. For example, if we see there's an extra chromosome number 21 in Down syndrome patient, so the total number of chromosome now becomes 47, right? Because one addition of chromosome 21. And then we put the sex plus 21, means this patient has extra chromosome 21. For chromosomal abnormalities can be divided into two. The first one is constitutional chromosomal abnormality, which the abnormality is present before birth, since birth. Number two is abnormalities due to acquired chromosomal abnormality. This one usually occur if the patient has a malignancy. All right, it occurred de novo. The types of chromosomal abnormality can be numerical and structural, as I said before. So for numerical, it is either increase in or decrease in the number of chromosomes. So any abnormality, so we just call it aneuploidy. For example, in trisomy, trisomy means a condition in which that individual has one extra copy of chromosome. In monosomy, the individual has lost or delete one copy of the chromosome, so it becomes 45. So it's a bit different from a triploidy, where the whole set of chromosome become 3. So the total number of chromosome now becomes 69. So this is, this is a picture of trisomy and triploidy. As you can see here, in trisomy, only one chromosome is extra, chromosome number 21. But in triploidy, the whole set of chromosomes are extra. The example of common numerical abnormality, you have to know at least 3. Chromosome trisomy 21 is associated with Down syndrome, trisomy 18 is Edwards syndrome, and 13 is Patau syndrome. For sex chromosomal abnormality, it is Turner syndrome when you have loss of one of the chromosome X, and Klinefelter syndrome. This is the most common syndrome for sex chromosomal abnormality that we receive in the lab. We go a bit detailed for chromosome 21 or Down syndrome. By far, this is the most common and the best known chromosomal disorder in human that is associated with intellectual disability. So for trisomy 21, for genetic abnormality, it can be divided into 3 abnormalities. Number 1 is a pure trisomy 21, or we call it non-disjunction type. This is the most common and usually is associated with age of the mother. But bear in mind, in our lab now we start receiving the patient with very young age, even 18 years old, 21 years old, with the baby of non-disjunction trisomy. So maybe we need extra research for this. Okay, number 2 is a mosaic type. This one contribute around 5% of the Down syndrome, where when we do the cytogenetic analysis, we will find that some of the cells are normal and some shows trisomy 21. And the last one contribute 2 to 5% of the cases due to translocation, any translocation that involve chromosome 21. Okay, why we need to know which type of abnormality that is present? This is very important because we need to tell the parent the recurrent risk to have a Down syndrome baby, because we know that for non-disjunction, actually the risk is very low. It is similar like other syndrome, 1 to 2% only, and it's according to the risk of maternal age as well. But if the mother carry the translocation, let's say 21 and 21, the risk of getting a baby with Down syndrome in next pregnancy is approaching 100%. So they will have either syndromic baby with Down syndrome or the baby with monosomy 21, which won't survive. All right? And this is the example of the picture for a patient with a non-disjunction type. This one is very straightforward because you can see addition chromosome number 21. This one is for female and male. And then this is for karyotypes carrier's mother, showing if you see that the total number of chromosomes become 45, because if you look here, one of the chromosome actually was translocated onto the chromosome 15. Right? But for this mother, there is no features of Down syndrome. Why? Because the net number of 21 is still 2. one here and one here, and the rest of the chromosome are still normal. But this is important because the offspring will have the problem. If the mother contribute this abnormal 15 to the offspring, so meaning that she will contribute 15 and 21. And then the total number for baby with this abnormal 15 will be 3. So end up with Down syndrome. So this is example of baby with mother of Down syndrome, carrier for translocation type, right? So the total number of chromosome 21 now become 3. 1, 2, 3, all right? For Edward, you can see here the extra chromosome is located at chromosome 18. 18, it means for Edward. And then for Patau syndrome, the extra is in chromosome 13. Patau syndrome is a very serious condition. Most of the time, the baby won't survive. Maybe they just survive up to 1 week only. And then we have Turner syndrome. You can see here only one X chromosome. In our lab, we receive a patient with Turner syndrome for investigation of primary amenorrhea. Because in Turner syndrome, the patient usually is a short stature and has primary amenorrhea with failure of the gonads, all right? In Klinefelter syndrome, this is also quite common in our laboratory. The sample received from ONG clinic, most of the time due to male infertility. The male with Klinefelter syndrome, this is male, okay? 47XXY, sorry. They have one extra chromosome X instead of XY, so they become XXY. So the chromosome is, the karyotype is 47XXY. The structural abnormality is any abnormality that involves the abnormality of the structure of the chromosomes. There are many types, but most of the time is the one that we always see is translocation. For example, in chronic myeloid leukemia, we almost every week, many sample that we receive has this type of translocation. One of the chromosome 21, part of chromosome 21 is translocated onto chromosome 9, and part of chromosome 29, chromosome 9 goes to chromosome 22, and you can see here the affected chromosome 22 is very small. So this is called Philadelphia chromosome. So in chronic myeloid leukemia, we can use this chromosome as a marker. So if the patient is having this abnormality, maybe it is a pathognomonic for CML. And we can use this as well for monitoring of the response of the patient's treatment to the drug, because we have a special treatment for this if patient has positive for PH chromosomes. For deletion, we have, for example, in MDS, we have 5q deletion, and in postnatal baby, we have few other deletion because of deletion that they present with some abnormalities. Inversion, and we have isochromosomes, we have ring chromosomes, and Robertsonian translocation. This is very important, as I said just now. One of the examples is in Down syndrome. Robertsonian translocation is actually any translocation of the long arm of 2 acrocentric chromosomes. Acrocentric chromosomes is a very small chromosome which has no P arm. They just have a little satellite above the centromere. So example, chromosome 13, 14, 15, 21, or 22. Why cytogenetics is very important? Number one is to confirm the chromosomal syndromes such as these trisomies, and then to identify the cytogenetic or genetic cause, if any, which is associated with abnormality in the children or multiple congenital abnormalities, mental retardation or growth failure, and then in couples with infertility problems. So a lot of them, sometimes we see a Klinefelter syndrome or Turner. Turner usually no menses, and then recurrent abortion. So other to confirm the genetic sex of the children with ambiguous genitalia or disorder of sexual development. I think Prof. Sultana will elaborate this further. And then to investigate the carrier status of parents of siblings with chromosomal abnormality. Let's say the baby is having abnormality of the chromosome addition of unknown material. So we will do the parental karyotyping to see what are the abnormality present on that baby. All right, and then to investigate the chromosomal abnormality of the fetus or for prenatal diagnosis for those who had high-risk pregnancy, advanced age, or when they find some abnormality during ultrasound, so we suggest them to do cytogenetic analysis. Next is to identify the specific chromosome translocation in malignancy, such as in leukemia just now, the CML. And actually we have a few other abnormalities for recurrent abnormalities for hematological malignancy. And the last one is to help the physician to monitor the progression of the disease and response of the patient to the treatment in CML, example CML. But we have the limitation for conventional cytogenetic analysis. As I showed you just now, the step to get a chromosome is not easy, so we need trained personnel to handle, and it is tedious, right? And it depends on the cell division and high quality metaphases. And some cytogenetic aberration we can't detect using cytogenetic analysis. We need other modalities. It affected by poor chromosome morphology. I think that's all. These are our team from Human Genome Center, led by Dr. Nazihah there, and we have Prof. Zilfalil as well. And this is our Prof. Sarina, the coordinator for Human Genome Center. So that's all. If any question, you can ask after this. Thank you.
The topic about, we can see the case discussion and some common genetic diseases from chromosomal to molecular diagnosis. Who knows the Prof. Sultana? Prof. Sultana has received his bachelor degree and master in the medical at University Diponegoro Semarang and taken his PhD in a medical genetic in Sydney. She has published more than 100. Her current appointed head of the Lab and Genetic Counseling Master Program at ERC University. She is also the president of the Indonesian Society Genetic Counselor. Before Prof. Sultana develops his lecture, I hope all the participants already logged in menti.com. Teman-teman yang ada di kursinya silahkan login di menti.com karena nanti Prof. Sultana akan interaktif dengan menti tersebut. Silahkan Prof.
Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone, and special thank you to our colleague from overseas who come and join with us. Dr. Aziati already said quite long explanation, so I just go to the cases of patient that can be diagnosed with cytogenetic and also cannot be diagnosed with cytogenetic. So just some cases. Yeah, this one also already been explained by Dr. Aziati about abnormality in the chromosome structure, yeah, and also chromosome number. This is the picture of the translocation, so the exchange part of the chromosome to the other chromosome. And this one is deletion, so part of the chromosome is missing, In this case, the patient will be abnormal, but in translocation, the patient is normal. And then this one is the inversion, so the chromosome just move to another side. Yeah, this patient also normal, but the children of this patient will be abnormal. It's the same like in translocation. And this is a derivation, so the chromosome is get additional chromosome from the part of the chromosome itself. And the last picture in the chromosome in the left side is about isochromosome. Isochromosome is the X chromosome in this example has both long arms. So one, the left side, it has normal chromosome X, but the other one has both two long arm chromosome without short arm chromosome. I will show you some example. Yeah. How to diagnose chromosomal microdeletion and duplication or single gene disorders when we having difficulty to diagnose using cytogenetic analysis. So conventional chromosome analysis cannot detect creative chromosomal abnormality less than 5 MB. And then also microdeletion, microduplication, or gain and loss of chromosome. Mostly those cases in rare diseases. And the next one, after we think that we cannot do the diagnosis using chromosome analysis, we go to the dysmorphology of the patient. Unfortunately, some doctor did not send any data, any clinical data about the patient. But if we have the clinical data, we can check what kind of syndrome actually this patient from the software. Yeah, there are many software in the. Maybe we can find also for free in the internet, like Fast2Gene is free. Yeah, Oxford Medical Database is subscribe. Possum also subscribe. Smith Recognizable Pattern Book. We can buy the hard book and also electronic book. This one also, electronic book is very helpful. And when we found that the possibility of the syndrome, and then we go to the molecular analysis. What kind of molecular analysis can be done? There are so many different molecular analysis, and the last one is the NGS. Yeah, we can sequence for the whole genome or for the whole exome. The red side is the picture how we do using Fast2Gene. Let me give the examples here. Chromosomal mosaicism in girl with disorder of sex development. The older name may be intersex, or some people say ambiguous genitalia, but the new name is disorder of sex development. This case is 20 years female, has primary amenorrhea, and actually from the cytogenetic analysis, we found 46XY in 70-30%, and only 27% 45X. And there is no palpable testis, yeah, or undescensus testicularum. And then from Hasike test was positive, means the testis is still working and the testosterone is higher than higher or normal. This patient said gender is not really an issue. I can be a man and I can be a female. It's hard when we give the counseling when the patient said like this. And then after genetic counseling, she just escaped. She never come, yeah. So we cannot do any monitoring. My question now, what information need to be informed in the genetic counseling session for her future life as a girl? Please choose one option, yeah, adjust her values. I go to the next one, I think. Yeah. 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 Okay. Yeah, we go the next one. Yeah. 2 years later, from laparoscopy, we found tumor in the pelvic cavity originating from the left testis or dysgerminoma. This cancer risk must be informed in the genetic counseling session to the patient. So whether they want to remove the testis or we want to keep, but the testis certainly atrophic. The next case, boy with 46XX, mosaicism and 46XY. He was 16 months at the time, and then karyotype we found 46XX and 46XY are only 15%, and gonad in the right is 1 ml in the inguinal region, and the left gonad cannot be palpable, so was absent, and then the phallus, we say phallus because we did not really know that he has testis, penis or clitoris hypertrophy, so we say phallus, 3.3 centimeter, and then he has also scrotal hypospadia, and the diagnosis was ovotestis disorder of sexual development, and the hypospadia was repaired for 2 times and still leaking, but then he lost of control. And then in genetic counseling session, which gender should be chosen? Female based on high number of XX chromosome, or white for his decision in the later life without genital adjustment, or just male or female? Yeah. Yeah. Okay, and I continue for the next one. In the further monitoring for the XX and XY mosaicism, gender decision is male, and 40 years later, he got his menstrual cycle and gynecomastia. After counseling, patient insists want to be a male. He confused with his gender identity disorder whether he is man or woman. So he's suffering from gender dysphoria. He afraid that his prior were not accepted as a man or woman. He fears social discrimination or stigmatization in the community. Information about infertility and sexual function to him, because he adult enough, might create stress. Internal genital evaluation was done, gonadectomy, hysterectomy, excision of mammary gland, because he insists want to be male. So we stop his menstrual cycle and also gynecomastia. The next one, this patient with hypospadia and micropenis, we do the chromosome analysis and microarray. Chromosome analysis in this case only to know whether this patient male or female. And we found this patient actually has 46XY. So he is a male. And from the microarray, we found deletion 0.17 MB. It's not very big, yeah, in chromosome 11p13. And this is actually in the region of WT1 gene. So we can establish the diagnosis using the microarray. That using cytogenetic, we only can say to the patient in the counseling that their children is a boy. The next one, I want to show you Prader-Willi syndrome. It's quite famous and quite a lot also, including in Indonesia, but some often cannot be diagnosed because we only use cytogenetic analysis. Yeah. This patient very typical with intellectual disability, obesity because of hyperphagia. He eat a lot, and hypogonadism. In this case, actually they have a paternal deletion, yeah, and also very rare can be diagnosis using cytogenetic. Yeah, this is from cytogenetic result. Very lucky if we can get the deletion from the cytogenetic analysis. Usually very hard to find. In the whole of my life, the first time I got this, yeah, and the others we cannot find, only from clinical data, and also now we can do microarray. Yeah, see here with microdeletion, or from here, not just microdeletion, yeah, because the deletion can be analyzed using chromosome analysis. That means the deletion more than 5 MB. Next one, this is actually in the left side is the test for fluorescent in situ hybridization. We can see that there are two pictures here of chromosome 15. On the top one has deletion, and the left and the bottom one has no deletion. And what is the molecular mechanism of Prader-Willi syndrome? Paternal relation, maternal relation, and that's cool. Yeah.
Izin Prof. Sultana, you may comment on the answers that the audience has chosen.
Yeah.
In case they pick the wrong answer, it may be explained.
Okay.
Thank you.
Time is 5 minutes. Yeah. This is the answer. Yeah. He has paternal relation. Yeah. And actually also maternal uniparental disomy is one of the cause of Prader-Willi syndrome, and also imprinting defect. Yeah. I show you the picture here. This is the normal one, and this is the paternal relations, part of the chromosome 15 in the region 15q1113 has deletion, and this is maternal UPD, means this patient do not have part of this father allele. And then this one is imprinting defect because the maternal allele did not print. And the right side is the Angelman syndrome. The Angelman syndrome is actually has the same abnormality like Prader-Willi syndrome, but in Angelman syndrome, not paternal relation, but maternal relation. Yeah. And they both also has genomic imprinting. Yeah, so they have mediated by mechanism of DNA methylation, and the methylated gene remain inactive, but unmethylated gene are expressed. Yeah, this is another test for Prader-Willi syndrome. The ECU a long time ago just tried to compare allele between the child and the father and the baby and the mother. So we can see here the allele of the father, the child is missing of father allele. Yeah. And another test also we can use segregation of chromosome 15, but the latest one we use the methylation study. We can also distinguish between Angelman syndrome and Prader-Willi syndrome. And another test just recently we can do using chromosomal microarray. You see here the red one is actually deletion in the chromosome 15q13. Yeah. So, but in the CMA, chromosomal microarray, we cannot distinguish between deletion of the father on the mother. So we have continued working on it with trio analysis, mean father, mother, and child. We can see that the duplication is actually from the deletion actually from father or from mother. Yeah, this is also a still picture of the chromosomal microarray, and this is the deletion. It's actually 5 MB. Yeah? So we cannot detect from chromosome analysis. Another case is about Turner syndrome phenotype. Yeah, from we analyze this from the chromosome to the gene. We can see here this patient with when come to us, she was 6 years old, and we found that she has 46XX. But the pediatrician insists that she has Turner syndrome because she is short, she has also a web neck, yeah? And then the patient come back when she is 15 years old, and then his head, her head is short, yeah? And then the pediatrician want to do the second cytogenetic analysis. We found still 46XX, yeah? No cell with 45X, mean there is no mosaicism with Turner syndrome. And the most important here, she has normal regular menstrual cycle. So certainly it's not Turner syndrome because Turner syndrome do not have a menstrual cycle usually, but she has a similar clinical appearance, yeah. And then another key to understand that she is not Turner syndrome. She has a heart abnormality, and from the gene analysis for PTPN11, we found actually in the child has deletion here, has mutation here, yeah, from A to C. This is the father and mother is normal. That means this abnormality is de novo. My question now, what is the main clinical difference between Turner syndrome and Noonan syndrome? Yeah. Yeah. So, yeah, the most important difference is the menstrual cycle of the patient because in Turner syndrome usually do not have a menstrual cycle. And the next one, this is also microdeletion. Sometimes we can diagnose using chromosome analysis, sometimes not, yeah? But mostly we cannot diagnose, yeah, using chromosome analysis. You can see here the P arm has deletion, and this one is more clear. Yeah? This is in the boy sent from the pediatrician with Fragile X syndrome. Actually, we found with prominent ears, and also hyperactive stereotypic like Fragile X syndrome. And when we do chromosomal microarray, we found that he actually has deletion 27.9 MB, quite big, yeah. And there are number of genes in this deletion is around 150 genes. And the next one, the boy with intellectual disability. He has long jaw, prominent ears, macroorchidism, and neurologic disorder. His sister, from the pedigree we can see, also has mild mental retardation, intellectual disability. And the question is, what tests must be done? Cytogenetic analysis, gene amplification with PCR, or southern blot analysis, chromosomal microarray?
Menti, please.
Oh, all correct. Because the code
All correct.
almost
All
all.
correct.
Just one. Continue still this case. Mother karyotype was normal, but his sister, the sister of the boy, has, here, something in the X chromosome. What is the presumptive diagnosis? Noonan, Down, Rett, or Fragile X syndrome? I think everybody can answer.
Another? Yeah, Fragile
Yeah.
X syndrome. Norman, is still normal. Rett syndrome.
Fragile X syndrome. Rett syndrome is similar.
Yes, Fragile X syndrome.
And still continue this case using PCR of FMR1 gene, Fragile X mental retardation 1. We found no fragile site detected in the mother, like I showed you before. And then she has low premutation, This is the mother, Fragile site easily detected in full mutation. So this is the boy. He has a fragile site because of full mutation, and the father is normal. And the girls, she is with mild mental retardation. She has a full mutation. We cannot see this band in this girl, so that's why she has mild mental retardation. And the next one still about microdeletion. This one also quite common in Indonesia too, after Prader-Willi syndrome. This patient has 22q, 11.2 deletion syndrome. They are very, very specific. Especially from the filtrum, usually long and thin in the upper lip, and from the name, velocardiofacial syndrome. So they have problem on velo, on the throat, and then the cardiac and the facial. Using cytogenetic analysis, we cannot detect this case. And using chromosomal microarray, we found from the chromosome 22 as deletion. This is the deletion. 2 MB. So small, less than 5 MB. This is the result of the chromosomal microarray. We can see here the deletion. Only 2 MB. The next one, this is very interesting. 2 adolescent girls with 46XX. You see here, 2 adolescents, 46XX. In this pedigree, written as a boy. But the other one is a girl. They was born as a female with genital ambiguity. Cytogenetic analysis only for sex assignment, but not for gender identification. Their gender then changed to male.
Menti, please. Menti, please.
Congenital adrenal hyperplasia is autosomal recessive. And then still continue this case, yeah. This patient actually in late identification, they already adult, yeah, and actually a recessive congenital adrenal hyperplasia. Diagnosis was confirmed as congenital adrenal hyperplasia. Two older girls, 46XX at 17 and 16, were changed to male, yeah, the other two. The youngest child was 3 years old, and we tried to inform to the family to be a female, but actually sexual reading as a female, but she behaved as a boy, and refused any medication for whole life, and later she changed her gender also as a male. The next one, I hope the last one. The new weight woman with primary amenorrhea, this patient come to us just new weight and with primary amenorrhea. And we see she has a scar here, and then in the inguinal region because of hernia inguinalis when she was 8 years old. According to her, there is no explanation from the surgeon what kind of hernia and what next. She had second surgery when she was 28 years old because of suspected incarcerated hernia. And then with gonad biopsy was done, chromosome analysis was 46XY, yeah, with normal female appearance. What is your possible diagnosis? Yeah, androgen insensitivity syndrome, yeah. But this type of CAI is complete androgen insensitivity syndrome. So androgen insensitivity syndrome has two types. The complete one is usually as a female appearance and female gender also. But for the partial androgen insensitivity syndrome, usually become a male. Yeah, still in our examination, the breast development was trainer 2, 3, also here, and then testis was palpable in the inguinal region. So that means the hernia inguinalis in the past is actually testis. Yeah. From the pedigree, her cousin died because she was diagnosed as ovarian cancer, and no karyotype done. Another cousin also has no period. Pedigree is very important. So in this case, pedigree really very helpful, and by interview with the patient, we can see that there are more patients in this family, and we can conclude that this patient has X-linked inheritance. Yeah, the diagnosis is confirmed with the ER gene mutation and maternally inherited as a complete androgen insensitivity syndrome. Genetic counseling was so difficult because this is a breaking bad news, and this patient has gender dysphoria, and then she wants us to keep the confidentiality to her husband. So her husband did not know what happened with his wife. So this is the last one. Recurrent risk is very low if parent is not a balanced carrier. Mendelian disorder carry high risk of recurrence, whereas chromosomal disorder have low risk. Single gene disorder, gene mutation cannot be detected using chromosome analysis. Thank you.
Please applause. Thank you, Prof. Stana. Terima kasih banyak. Thank you very much. Very interesting. We still not enough time to have a discussion, but the committee asked me to make a quiz in front of your table. And on your table we have a quiz, please. 5-minute quiz. And then I invite one person to the members want to ask question. Maybe you can.
Yeah.
Yes, this is a quiz.
Yeah.
This one.
Yeah, please scan the QR code and it will bring you to the link to answer the 4 questions, and hopefully our experts going to comment on the quiz. We're going to show the result live.
Yang tadi yang nomor 1, Prof. Diminta diterangin lagi sebetulnya. Yang nomor 1 itu Prof belum jawab. Yang slide yang 1 pertama, 1 tadi. Iya, yang kromosom. Yang pertama.
Somebody asked question for the case 1. Yeah. With mosaic chromosome abnormality. Yeah. For this patient, theoretically and ethically, we cannot decide what the gender she want or he want. So, but we can say that risk of having malignancy from the abdominal testis is correct, yeah, because he has a mosaic XX and XY, so there is a possibility he or she has also very atrophic testis in the abdominal. Sometime or most of the time, urologists and OBGYN cannot also evaluate using laparoscopy. Yeah, and this patient actually run away from us, escape, so we cannot follow the condition of them. So, but in Indonesia, culture is more important. So usually parents will decide what is the gender of the baby, because they need birth certificate, and especially when they want to go to school, they need birth certificate. So they push us to give a kind like birth information from the hospital that they are a boy or a girl, but we will not do any sexual adjustment. Yeah, we wait until they grown up, and it has happened in this patient. And after he grown up, 16 years old, then he actually got a menstrual cycle and also gynecomastia, and he insists by himself, not pushed by the counselor or by the parents. So we help him to remove all the uterus and also the mammary gland to make him happy to be a male. Yeah, so avoid the gender dysphoria.
Ya, terima kasih Prof. Thank you very much. Any question? Or if after 2 discussion we know the chromosome and how identification the chromosome in the lab, and the most important thing, how to diagnose, early diagnose from the for this moment. Terima kasih untuk teman sejawat yang dari UI di Objin, saya tahu ada nih sekarang. Terima kasih untuk kehadirannya. Kemudian ada nih yang tukang bedah-bedah ya. Jadi terima kasih banyak, kita semua malam hari ini. Kami di YARSI cukup senang sekali bisa hadir di dalam workshop ini, pemanasan dari Prof. Sultana. Jadi sekalian kami mengenalkan bahwa DRC sekarang sudah bergenetik, Bu Ning sudah dengan teman-teman sudah siap dengan menerima student master untuk belajar lebih lanjut di dalam genetik. Ya, buat saya jadi banyak belajar. Sebagai pediatrician kami menerima dari obgyn anak-anak yang pasien-pasien yang mukanya nggak kelihatan baik atau panalah yang kemungkinan dicurigai kelainan genetik segera dikirim. Prodia juga ada ya, nanti kita juga siap ya Prof. Itu saja saya pikir saya sudah dihitung-hitung waktu. Jadi belajar kromosom buat saya nggak cukup 1 jam. Kita hari ini 1 jam dalam 2 speaker, yang pertama bagus, yang kedua bagus dan semua bagus. Tapi kita masih ada waktu beberapa 2 hari ini sampai 3 hari Sabtu saya pikir kita bisa berdiskusi lebih banyak. Terima kasih, saya mohon maaf di dalam memoderator program ini, mudah-mudahan bisa bermanfaat buat kita semua. Terima kasih. Wallahul muwaffiq ila aqwamit thoriq. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Dr. Wan. Next, we will have the second session on genetic counseling practice. And we hope to enlighten you on the process of genetic counseling and highlighting the process and the role of a genetic counselor in diagnosing, managing, and educating the patients. The facilitators for this session is Professor Sultana, and you've had an introduction on Professor Sultana. And our second facilitator is Dr. Nurin Listiasari, MSc Med, Genetic Counselor from the RSAB Harapan Kita, Jakarta. I'd like to invite Dr. Nurin as well with Prof. Sultana for the second session. Dr. Nurin obtained her MD from Diponegoro University in 2014, and she has been working for almost 2 years in RSAB Harapan Kita as a genetic counselor. She had finished her doctoral degree as part of Beasiswa Pendidikan Magister menuju Doktor untuk Sarjana Unggul from 2019. Okay, Prof. Sultana and Dr. Nurin, you may begin the second session.
For the benefit of the audience, we would like to ask Dr. Aziati to comment first, Izin Prof, on the first 2 questions. What is the right answers? And because apparently some of the audience pick not ideal answers.
The question number 2, right? Regarding cytogenetics, number 1, it is about the study of DNA. I put it as wrong because by right, the chromosomal study, it is, cytogenetics is regarding chromosomal study. Then number 2, human has 23 pairs of chromosomes, so this is correct. 23 pairs, so meaning 23 times 2, so 46 chromosomes. And then number 3, chromosomes are best visualized under microscope during anaphase stage. I think everyone answered correctly. It is wrong because we need to see during metaphase. All right? And then chromosome can be grouped based on the location of the centromere. This is also correct. So during the karyotyping, we put the chromosome that is at the same centromere. So we know the type of the chromosome based on the location of the centromere, whether it is metacentric, submetacentric, or acrocentric. And then it helps to monitor the response to the treatment for CML patients. So this is also correct. I think everyone answered correctly this one as well. Then for the chromosomal abnormalities, consists of numerical and structural. Correct, okay, good. And then Klinefelter syndrome showed 45X karyotype pattern. Wrong, right? Okay, good. This is for Turner syndrome. For Klinefelter, it will be 47XXY. Okay. Then trisomy is a condition in which there are 3 haploid sets of chromosomes. So this is wrong. This is triploidy. Yeah, good. And then Robertsonian translocation involves the translocation of long arms of 2 acrocentric chromosomes. So this is correct. Okay, I think everyone answered correctly this one. Okay. If you have any other question, maybe you can email us later. All right? Okay, thank you.
Ahmad bantuin saya ya. Tapi enggak sekarang, Pak.
Mau sekarang?
Ah,
Mau sekarang nggak?
iya. Ya, terserah mau sekarang ya.
Sekarang mungkin
Pak Ahmad suggested me to also explain about the answer from the audience, such as in the question number D, chromosome analysis was done in patient with suspected partial androgen insensitivity syndrome. Please choose one. The correct answer is gender identification can be confirmed. But, so using chromosome analysis, we can only confirm the gender identification. We cannot make any diagnosis. So for the diagnosis, we have to do ER gene mutation analysis. Yeah, that's the reason. So some people, almost 22% say mutation in ER gene can be detected. Yeah, but the question is chromosome analysis. Okay? Yeah. Yeah. Ini gede nih, Bi.
Cepat, ini mau.
Gede nih. Tadi kan saya tak gede nih.
Oh,
Nah,
ini aja.
nah,
Prof.
iya. Oke.
Oh, ini kalau enggak ini Prof. Display settingnya.
Tadi kan gede ya.
Kayak gini ya, Prof.
Iya, aku pembukaan aja ya.
Oke.
In this presentation, actually, I will give the talk with Dr. Nurin. She actually was my excellent student. That's why I took him to join me in this case. And almost all these cases here, we were working together. Yeah. In this presentation, most of the cases are rare disease. Yeah, but some people still maybe couldn't understand what is actually rare disease. Rare disease is, some people say it, never seen before, unbelievable, unrecognized, or unusual. When one comes to know that he or she is suffering from something which is different kind of disorder and is rarely seen, say on 200,000, like this data actually 200,000 from America. So different country, they have different number. From the left side, we show you the table. Yeah, it's a bit confusing because some countries said not too high, but some countries said it's high. So we just see from the American is 200,000 in the population is a rare disease, 1 in the 200,000. Yeah, we have just recently, I think 1 or 2 years ago, this case. Also, this is actually a rare disease, very interesting. I think every Indonesian see this picture from the newspaper. What is actually the question from the affected or from the parents in rare disease is a very sad question. Am I unlucky to be cursed with this disorder? Or am I correctly diagnosed? Is this curable? This is a lot of question about that. If so, how expensive is the treatment? And what will be the success rate of my treatment? Yeah, almost all the question is very difficult to be answered. And in rare disease, usually the diagnosis is delayed. Some of our patients said almost nearly 10 years can be diagnosed, and none from them less than 2 years. And very lucky now we have NGS, so some of them can be diagnosed. Let's go now to the case. First case will be presented by Dr. Nurin.
Thank you for your kind introduction, Prof. Sultana. So Prof. Sultana is my teacher and she was my promoter during my master and doctoral degree. And Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. My name is Nurin and I'm a genetic counselor in Harapan Kita National Women and Children Hospital. So I'm very honored to be here to share my experience with you during my genetic clinic. And let's start with case number 1. So maybe some of the cases already been presented by Prof. Sultana before. I just want to make a quick presentation and we will more discuss about the genetic counseling. So a girl come to our clinic because of primary amenorrhea. She was 20 years old and she has no menstrual period at all before. Based on the history taking and also the physical examination, she revealed have a minimal breast development, which is standard 3, and also absence of axillary hair, and she has a female external genitalia with scarce pubic hair. So as we can see from the Prader stage, so we use Prader stage for this patient. She has a Prader stage 1, so the external genitalia resemble a normal woman. However, based on the physical examination, she has a bilateral solid palpable mass in the inguinal region. So we are thinking, what is this? What is the mass on the inguinal region of this patient? And after a history taking, she said that she has a younger sister, which is 12 years old, who have a similar condition. She diagnosed with unilateral inguinal hernia when she was 2, and she had a surgery for this inguinal hernia when she was 11 by a general surgeon in the rural area. However, the doctor didn't explain what is the mass and about the diagnosis. So the patient didn't know what happened to her and her sister. Now, so this is the question. Based on the pedigree, what is the mode of inheritance of this patient? I would like to invite all of the participants to join the Menti, so you can choose which one is the correct answer for this case. Okay. Sorry. Okay, I will start the Menti. So based on this pedigree, as we can see, the patient have a sister who has the similar condition. Okay, please join the Menti and answer this question. Okay. Jawabannya belum. Jawaban. Kalau mau show jawabannya di mana?
Oh, show jawabannya. Iya, iya, oke. Ya.
Baru ini.
Negara dibongkar mau nanti.
Iya.
Nah ini udah jalan lagi.
Ya.
Belum.
Apologize for the technical issue. So, from the quiz, as we can see, most of the participants choose X-linked and also autosomal recessive inheritance. Maybe I will comment a little bit about this question. So from the pedigree, as we can see, there are two siblings who have the same condition, and there is no other family member who have in this condition in the same generation and also in the other generation. So as a genetic counselor, usually I think it may be autosomal recessive, but is it true? So I agree with some of the participants who choose the X-linked and autosomal recessive because at the first time I met this patient, and also I also think maybe this is a recessive condition. And let's move to another question. Following the physical examination and also the history taking, from the genetic counseling session, I would like to suggest the patient to do a genetic test. So which one, which type of genetic testing is advised on the first line for this patient? Okay, I think all of the participants, most of the participants got the correct answer. So the genetic test on the first line for this case is the chromosomal analysis. As Prof. Sultana mentioned before, in some cases with the ambiguous genitalia or maybe primary amenorrhea, we often suggest the chromosomal analysis to establish what is the karyotyping of this patient. So from this patient, as you can see, from the chromosomal analysis, it revealed that the patient has the 46XY chromosome. And also, because we are thinking that the patient might have a monogenic disease that cause this phenotype, we also order a sequencing test for this patient. Based on the clinical examination, we're thinking that the patient have the androgen insensitivity syndrome. So we choose the Sanger sequencing for the AR gene. The patient have a pathogenic variant in these genes, which A to G change. So it's caused different protein product which should be ASN to serine. So AR gene is a gene, AR androgen receptor gene is a gene that produces the protein called androgen receptor. So the androgen receptor should be bind to the testosterone hormone to the development of the normal male genitalia. If there is something happen to the AR gene, or maybe there is a mutation or a pathogenic variant on the AR gene, so our body cannot produce the androgen receptor, and then the testosterone hormone cannot bind to the receptor. So our body cannot develop a normal male genitalia. And in the genetic counseling session, for the case of androgen insensitivity syndrome, we explain to the patient and also the parents about the mode of inheritance. We explain about this condition. It's called, it's have X-linked condition, which means the mother is the carrier of this condition, and the mother will pass this condition to the male child. This is the explanation of the X-linked inheritance, and also we also identify the family member who at risk. So if the patient have a sister or maybe auntie or maybe another family member who have the similar condition like primary amenorrhea or the others, so we would like to call all of the family member to have the same test on this patient. And also we discuss about the sex assignment of this patient. In Indonesia, usually the family member will influence the decision of the sex assignment. So in this case, usually patient with androgen insensitivity syndrome will keep the female gender. So there will be no sex assignment on this case. And we also explain to the patient about the reproductive health. So we explain about the infertility and also about the short vagina. If the patient will be married someday, they may develop dyspareunia or maybe difficulty during the sexual intercourse. So we will refer this patient to have a consultation with the OBGYN. And we also explain the risk of the gonadal malignancy, even though the risk of the gonadal malignancy of this patient is considered low, as only 1% of the patient with androgen insensitivity will develop a gonadal malignancy. And we also discuss this patient, and we will discuss the patient with other specialists in MDT team to the management of the patient, including give the supplemental calcium and also vitamin D, and also the possibility to have a removal of the testis, and also estrogen replacement therapy for the future. I think there is the point that we discussed in genetic counseling session about these cases. Okay. For the next cases will be presented by Prof. Sultana. Prof. Sultana.
Yeah. The second case about intellectual disability. There are two brothers, 8 and 10 years old, with intellectual disability, come to our laboratory with their mother and referral letter from pediatrician for genetic testing. Their mother said that their cousin from mother's side also suffer from intellectual disability. They have similar symptoms such as hyperactive and hand twitching. Belum ada questionnya ya? Yeah, this is the question. What is the pattern of inheritance of this case? Please look at for the pedigree. Two boys in one of the pedigree and the other two boys in their cousin. Kok nggak keluar jawab? Nggak keluar jawabannya Pak ya? Tadi lagi. Cukup dengan graf. Cukup dengan graf Mbak, tadi kan keluar. Udah.
Modelnya ini mau
Ya,
dibuat
graf.
batang aja.
Ya udah, graf nggak apa-apa.
Oh, ya.
Ya udah kelihatan tuh ya. Most of the participant reply X-link ya. I think this is the correct one, X-link. And what is the diagnosis? From the pedigree, we can see there are two boys in one of the pedigree, the proban, and there are two other boys in other pedigree. So that's mean the affected is all boy. So this is X-linked. Now, please look at the pedigree. Who is the first carrier to transmit this syndrome in this family? Please choose just one. Yes. The correct one is grandfather. Please be careful to watch the pedigree. Because this lady actually married to Tam, the first married with the older brother, and the second married, the lady married with the younger brother. And from both men, they have fragile eggs. And the fragile eggs not in the first generation, not in their children, but in the third generation, so in the grandchildren. If the carrier come from the grandfather or normal transmitting male, so they are normal, but they have premutation, and then all the daughter will be a carrier and no affected at all, especially the boy, but the grandchildren will be affected. Yeah. Here is the lady. This is actually brother. Yeah, the first husband and the second husband. And look at this from this first generation, there is no affected, but in the last generation, we found affected. Yeah, for this fragile X syndrome in Indonesia, nggak ada pertanyaannya. Okay. Yeah, in Indonesia with lack of facility, what you will do? I mentioned in Indonesia, yeah, with lack facility, and actually we do. Most participant give the correct answer. Yeah, we do usually with cytogenetic and PCR. Yeah? Cytogenetic can diagnose the full mutation, either male or female, and then PCR can amplify the pre-mutation but cannot amplify the full mutation. Let me show you this picture. Yeah, this is the fragile site. Yeah, so the mother must be full mutation, so she has fragile site. If she has only pre-mutation, the fragile site will not come up. And then for the PCR, we see here the mother has pre-mutation, but the boy here has full mutation, cannot be amplified, and the boy here, the red one, yeah, full mutation cannot be amplified by PCR. And then this one, the daughter with high pre-mutation. Yeah, actually the correct, the gold standard for FMR1 mutation using southern blot. Yeah, this is the southern blot. Yeah, we clearly can distinguish affected or non-affected because we can see here is the band of the affected. But another study also using protein analysis using ETC yang pakai antibody namanya, kok lupa saya, yang di PA tuh. We can see here that when the patient has protein product, we will see the color of brown, but if no protein product, they don't have the color of brown. Yeah, so this is in the normal one with the protein product, this is in the normal one. And this fMRI protein detection can use the root of the hair or the blood. Just normal blood. Immunohistochemistry, sorry, I forgot. Yeah, this test with immunohistochemistry. And the other study also use Sanger sequencing. Again, Sanger sequencing also cannot amplify the FMR1. Look at this is 55 repeat, so only pre-mutation, cannot amplify full mutation. And another study then after we have RT-PCR, you see here for the full mutation has a high melting curve, yeah. But this testing cannot distinguish also between male and female. So if they have a high full mutation, only we can see from the high melting curve. Please choose one for the most important task of genetic counselor. Oh ya, Ada. Yeah, only 18, 21, 22. This is the correct answer. That's okay, yeah. So genetic counselor in the post-testing have to explain about the result of the test and then the pattern of inheritance and the risk of having more children with the same condition. Another person is a girl with absence of menstrual period. Yeah, a 16 years old girl come to our CC clinic with their parents because of primary amenorrhea and experiencing masculinization. Her skin look dark, especially in the genital region. She has younger brother with the sex ambiguity. Look at from the pedigree here. This is the patient, the proband, and she is a girl, and she has another family with the same condition, and also cousin. Yeah, both is the test must be done first in this case. I think almost the same question with the previous question. Yeah. Mostly answer all. Karyotype and hormonal analysis. For the first line, we do a karyotype first to know that whether the girl and the boy is actually has the same karyotype, because the affected one is some girl and also boy. Yeah, from the cytogenetic analysis, we will see actually the affected is a male or a female, and then we can see what is the pattern inheritance, and we can also diagnose. Yes, hormonal analysis also needed, but the first one is cytogenetic analysis. On physical examination, he has clitoris hypertrophy, hyperpigmentation on the genital area, introitus vagina, in the first child only, but not in the other children, and short stature. What is the diagnosis of this case? Yeah. The correct answer is congenital adrenal hyperplasia, although all the children do not have the same physical appearance, but they all have 46XX, and also from the data we already given is actually data for the congenital adrenal hyperplasia, such as hyperpigmentation and also clitoris hypertrophy. This is the patient, yeah. This is the first patient come to us, yeah. She's a female, yeah. She has a hyperpigmentation on the genital area, but the other brother has like a male appearance, yeah. And what is the pattern of inheritance now? Okay, all affected has 46 XX. If X-linked inheritance must be 46 XY. So this pattern inheritance is autosomal recessive. Now hormonal analysis. The diagnosis must be confirmed with hormonal analysis. What hormonal test must be done first? Yeah, because too many hormonal tests, but the first one to establish the diagnosis. Yeah. Most the answer is 17 hydroxyprogesterone is correct. Genetic counseling session, what is your number priority for the counseling? Number one priority. Yeah, I think the same with the previous question. Yeah, because time is limited. Still another one case. Yeah, is most of the participants give correct answer. Inform the pattern of inheritance and the diagnosis, and most important in congenital adrenal hyperplasia, take the medication for whole life. Yeah, for whole life.
So let's move to the last question of this session. So this is a very interesting case. There is two family who come to us with this condition. So the family one, two sisters refer to our clinic because of the hyperpigmentation on the face, trunk, and extremities, which progress since childhood. And based on the pedigree, she also has a older sister who has the ocular abnormality confirmed as malignant melanoma, and the sister also have the similar condition. She also has a lesion on the cheek confirmed as basal cell carcinoma. I hope you can see the picture clearly here. On the face, there are hyperpigmentation on all over the face, and also the abnormality on the eye. And the second family referred to our clinic because of the freckles-like hyperpigmentation spot generalized on the face, upper part of the trunk, and also the extremities. His sister also has the similar condition. They both of them have the eye abnormality, which is cataract and dry eye, and in addition to the malignancy on the lips and palpebra. So the question is, what is the initial diagnosis for this patient? I would like to invite all of you to answer the question on the Menti. So the first option is acanthosis nigricans, the second one is XP, xeroderma pigmentosum, and the third choice is UV sensitivity syndrome and neurofibromatosis. So which one may be the initial diagnosis of this patient? I think most of the participants choose the correct answer. So how we differentiate the initial diagnosis of this patient? If the patient come to us and we are thinking, what is the diagnosis? So for the acanthosis nigricans, it's a skin condition characterized with the dark and the velvet patch of the skin. It is usually related to the type 2 diabetic. If the patient have the diabetic mellitus and have a dark skin on the neck, face, or maybe the armpits, we are thinking of the acanthosis nigricans. And what about the UV sensitivity syndrome? This is for the UV sensitivity syndrome, the patient have a hypersensitivity of the UV light from the from the sun. So the patient usually have photosensitivity, redness on the skin, and also freckles. And for the neurofibromatosis, is a genetic condition that there is a genetic condition which tumors on the nerve tissue. So in the neurofibromatosis, usually the patient will have a specific spot called the cave au lait, and also they have a small nodule all over their body, and the patient may have intellectual disability for the neurofibromatosis. And for this case, the correct answer is the Seroderma pigmentosum. Seroderma pigmentosum is a specific condition, is a genetic, and it is usually a specific clinical hallmarks, which is identified with the malignancy, which is a skin cell, basal cell carcinoma, or maybe squamous cell carcinoma, or maybe melanoma. And also there is a involvement in the neuromuscular and also eye involvement. Okay. So what is the pattern of inheritance of this case? As you can see in this pedigree, there is 2 affected family member, and the other family, they also have 2 affected family members. I think most of the participants choose the correct answer. So the pattern of inheritance of this condition is autosomal recessive. And which genetic test would you recommend for this patient? Chromosomal analysis, MLPA, FISH, whole exome sequencing, or FLIP. Okay, most of the participants choose the chromosomal analysis, and half of the answer is the whole exome sequencing. So for the Seroderma pigmentosum is a monogenic disease. The chromosomal analysis cannot detect this mutation. So in this case, as a genetic counselor, I will suggest the patient to do the whole exome sequencing. And from the whole exome sequencing analysis result, it showed that the family 1 have the pathogenic variant on the ERCC2 gene, and the family 2 have a nonsense pathogenic variant on the XP gene. So all of these gene, it's work in a DNA repair pathway. So if there is mutation of the pathogenic variant identified in this pathway, it will develop malignancy and also hypersensitivity to the UV. There are many genes involved in the Seroderma pigmentosum, and in our patient, we identified the mutation in the XPC and also the ERCC2 gene. And from the genetic counseling aspect of the Seroderma pigmentosum, I will explain to the patient and the family members about the mode of inheritance. So this condition inherited in an autosomal recessive manner, and I would like to also identify at-risk family member if they have a sister, cousin, aunt, uncle maupun auntie. So they can come to us so we can explain more about this condition, and also maybe we can do tests also for this patient. And also the important thing is family planning. If the patient want to get married, so we can explain there is technology to choose. So we can choose the baby which one is not inherited this condition through the pre-implantation genetic testing before pregnancy. So we can explain all of this thing during the genetic counseling session. I think that's all the cases for this workshop. Thank you for your attention. And for the MC.
Okay. Yes, thank you to our facilitators, Prof. Sultana and Dr. Nurin. And we will have quiz next. Okay, you can scan the barcode again on the table. You will have 2 minutes to complete the quiz. Okay, now we have the answers. Maybe Prof. Sultana or Dr. Nurin will be able to comment.
Almost all participants has correct answer. Yeah. Post-testing counseling explain the result of the genetic testing, the pattern on inheritance should be also the risk of having more children with the same condition. Yeah. Apa nggak tertulis? Yeah, it's the same. Yeah. Ini tuh ya. Next. Yeah. Sama, udah tak sebutkan tadi. Yeah, again, most participants give the correct answer, yeah. And almost the same question also. Only the paternal inheritance is different. Like for adrenal hyperplasia is autosomal recessive, yeah. So if we look at from the pedigree, we have to draw the pedigree for 3 generations for the genetic disease. So we will see that the affected only in the last generation. So if the affected in the last generation, and especially when they have consanguinity merit, we think that this is autosomal recessive. Yeah.
So the question for the question number 3. So as we know that pedigree construction is very important in the genetic counseling session. So which one is the correct pedigree? I think you still remember the picture of the option. So for the female, should be drawn as a round, while the male is square. And also for the carrier, we put the dot, the little dot in the center of the picture. And also for the marriage, usually we put one straight line for the male and the female. If they divorce, we put 2 separate line. And for the consanguinity, we put 2 straight line between male and female. I hope you will be understand about my explanation because there is no picture here. And for the last question, yeah, which one is the core component of the genetic counselor role? So all of them. So as the genetic counselor, we work not only with the patient but also with the family, usually extended family member. And also we ensure people culture and belief. We appreciate all of the belief of the patient. So we are helping the patient by explaining the genetics condition that they may have, and we will help the patient to take the decision by themselves. So yeah, there is the important things in genetic counseling. Thank you for your participation in this quiz.
Okay, big applause for the speakers. And now we would like to invite all the speakers from session 1 and session 2 to the front of the stage for certificate presentation and group picture. So please, Prof. Sultana, Dr. Nurin, and then Dr. Wan. Okay, Dr. Wenning will be presenting the certificate. Dr. Wenning is the chairman of the organizing committee of this symposium. Thank you to our guest speaker, Dr. Aziati Azwari Anwar from the Human Genome Center, University Science Malaysia. Thank you to Professor Sultana Farad from Universitas CRC. And thank you to Dr. Nurin from RSAB Harapan Kita. Thank you to all our speakers for the first and second session of this workshop. And thank you, Dr. Wan, for moderating the session. Thank you to all the speakers. And I would like to bring us to the next event will be lunch break and prayer break. So I'd like to invite all the guest speakers to step outside of the auditorium, and you will be led to the lunchroom for all the guest speakers. If you may proceed, we will have our attendants guiding you to the lunchroom. And then to all participants, lunch will be available near the registration table, so you can pick up your lunch at the registration table. We will invite you back for the next session starting at 1 p.m. So we hope that you can be back in time for the next session at 1 p.m. Thank you.
Hello, everyone. Thank you all for inviting me to this workshop. My name is Sung Ryu, and I'm part of a medical genetics division at 3 Billion, a genetic test company based in Seoul, South Korea. The title of today's my talk is Rethinking Clinical Practice in Genomics Era. Before I start my presentation, I would like to ask this question first to gauge the understanding of the audience today. So the question is, what is not considered advantage of panel sequencing have over exome sequencing? I'll wait a couple minutes so everyone can answer these questions. Looks like most of the audience here today have picked all of the above. I'm not gonna release the answers yet, but I'm gonna repeat the same question at the end of the presentation to see if everyone have understood what's the difference between the panel sequencing and exome sequencing. So currently, there are many different clinical genetic test methods that are currently available out there, and some of them have been around for a long time. And most audiences here today are probably very familiar with them. You can divide the clinical genetic test into two different types. First, there is a cytogenic test, and there is a molecular genetic test. Usually, So usually for a pediatric patient who are suspected of having a genetic disorder, tests are performed starting from the left to the right. In this presentation, I'm not going to go too much detail into cytogenic tests, but their test scopes are usually larger, but their resolution tends to be lower. Then there we have a molecular genetic test, which we will focus our talk today. We can group this molecular genetic test into two different categories. First, there is a targeted testing, and then there is next generation sequencing test. Targeted testing is basically usually performed using a Sanger sequencing method, which has been a golden standard of molecular sequencing for a really long time. These include testing for presence of single nucleotide variant, such as testing for presence of BRAF variant in cancer patient, or MLPA can be also used to detect a small copy number changes. Example of MLPA would be testing for DMD exonic deletions and duplications in patients who are suspected of having a Duchenne's muscular dystrophy. However, more recently, with reduced cost of next-generation sequencing, many of these targeted testings are being replaced by next-generation sequencing, or in short, NGS. And these NGS tests are divided into three different subtypes. First is the panel test. Basically, panel testing is basically testing multiple genes at the same time. With introduction of NGS, the panel testing became quite popular. In the past, when Sanger sequencing was used to test multiple genes, a panel size was very small because it was very resource intensive. But now there are panels that can that sequences hundreds or even thousands of genes at the same time. And depending on what your patient symptoms are, specific panels are usually ordered. So for instance, if a patient has a hearing loss, then you will have to select a hearing loss panel. As you have noticed it, if you have used the panel testing before, each company offers slightly different versions of panels. As you can see in here, even within the retinal gene panels, several different gene panels are offered depending on the specific symptoms of patient. Then there is a genomics test, which are exomes and genome. For purposes of this presentation, I will mostly focus on exome testing, but their advantages are very similar to each other. Exome testing basically sequenced almost all known coding regions of human genome. This is about 1 to 1.5% of entire human genome. And it includes the genes that are not yet disease associated as well. Before I go a little bit further, I'm gonna give a little short question. What is size of human genomes? And I'm gonna start the poll right now. Looks like many people have guessed it right. The correct answer is 3 billion base pairs. And this is where our company's name 3 billion comes from, 3 billion bases of human genome. Since majority of pathogenic variants are within the exonic coding regions of human genome, exome testing is by far the most cost-efficient way to identify a disease-causing variant when a large number of genes need to be tested at the same time, or when it's very difficult to specify what gene needs to be tested based on the patient's symptom. Pretty much any patients who are suspected of having a genetic disorder can be tested on exome. Then, of course, you might ask, when should you be using a panel sequencing, and when should you be using an exome sequencing? So let's compare the panel sequencing and exome testing. Here is an overview comparing advantage and disadvantage of panel and exome. I want to first focus on advantage a panel have over exome testing. First advantage is that since the panel testing can be easily customized. Since panel test targets fewer genes compared to exome, panels can be easily customized to include various targeted regions when they are designed. So for example, when there is a known pathogenic variant within an intronic region, such as this case, exome test will not be able to detect this intronic variant within the intron. However, panels can be designed in a way to include these intronic regions to give the testing more flexibilities. Also, although this is also possible with the exome to a certain point, panels have a greater flexibility when it comes to designing different regions. The second major advantage is that panels have a higher depth of coverage compared to exome. Since panel targets fewer genes compared to exome, coverage of each region are often much higher. So here's our second question. Does everyone here know what the advantage does higher depth of coverage give when it comes to the testing? All right, so it looks like there are 3 people who have answered this right. The advantage the depth of coverage gives is that it helps in detection of small CMBs and mosaic variants. So since the higher coverage gives more coverage in a particular region of the gene, it's easier to detect a mosaic variant when it's present in the very low variant allele frequency within human genome. Also, copy number variant, or short for CMB, can be called using both in panel and exome. Both of the methods often utilize depth of coverage difference to call out the copy number differences. With higher coverage per exon in gene panel, they can call out heterozygous CMBs that are as small as 1 exons long. However, in exome, which depths of coverage are often much lower compared to panel sequencing, 3 or more consecutive exons needs to be deleted in order to call out heterozygous CMB confidently. This information was now listed in OMIM database with the disease name radio-Tartaglillar syndrome now. So just after 2 months, patient was able to receive a positive report by reanalysis of existing exome sequencing data. Of course, this is a little extreme example that patient was able to receive a reanalysis report just after 2 months, but shows you why reanalysis is a very important part during diagnosis odyssey. The third advantage exome testing have is that exome sequencing can identify secondary and incidental findings. To illustrate this, let me show you why secondary and incidental findings are important. Here's a case example. The patient was 1-year-old Korean female. She was ordered on exome sequencing with the indication that she had a non-syndromic hearing loss. And there was no family history, and she had no recordings of previous genetic tests. When, upon inspection, we have identified a heterozygous variant in ILDR1 gene, which is associated with autosomal recessive deafness. If this was a panel test, the patient would have received a report with a heterozygous variant in ILDR1 gene with the unmatched zygosity. However, because this was an exome test, which includes all coding region, we also identified a heterozygous 1.3 megabase deletion in chromosome 16. This region includes ANKRD11 gene, which is associated with KBG syndrome. It's also known as 16q24.3 microdeletion syndrome. KBG syndromes are associated with a short stature, craniofacial findings, macrodontia, and global developmental delay, as well as a hearing loss. As the patient's phenotype was a non-syndromic hearing loss, it did not match with the finding. Therefore, we communicated with the referring physician to check if the patient shows symptoms of KBG syndrome. After the call, the physician re-examined the patient in the context of additional findings, and she noted that the patient indeed presented with motor delay, short stature, and macrodontia of upper incisor that fits well with the KBG syndrome. If this was done using a panel, like I said before, patient would have received a heterozygous variant in ILDR1 gene and might have gotten multiple other unnecessary tests to try find second variant. And this demonstrates the power of exome for even simple non-syndromic cases. Finally, the panel can also miss out potential gene of interest that are covered by exome test. To illustrate this a little bit further, let me show you our diagnostic rate from us for adult patients who were referred to us with left ventricular hypertrophy, suspecting hypertrophic cardiomyopathy. As you can see here, out of 18,020 patients, 450 patients were able to receive a diagnosis, resulting diagnostic rate of around 25%. And we were able to identify disease-causing variant in 49 different gene and loci. When we compare this information to two commercially available cardiomyopathy panel from two different companies, we were able to see that only 75 genes were shared between two panels. And therefore, in order to make sure all of the cardiomyopathy related genes are covered using panel, you would have to need to perform two different sets of panel tests. When we compare these genes to our data, out of 49 different gene and loci, we identified that 17 genes were missing from either of the panels. This accounted for 42 patients and that would have been remained undiagnosed if they received panel instead of exome. This accounts for roughly 10% of entire diagnosis we made. And one of the genes that were missing in cardiomyopathy panel was MTTL1 gene. MTTL1 gene is a gene in mitochondrial genome that codes for mitochondrial tRNA. It's associated with a mitochondrial myopathy called MELAS. And common MELAS syndrome includes seizures, myopathy, and hearing loss. Then you might ask, how is this related to cardiomyopathy? But due to mosaic nature of mitochondrial genome, non-syndromic later onset hypertrophic cardiomyopathy are also well described in the literature. You see that about 1.5% of all HCMP patients from us were able to get a result from a pathogenic variant in MTTL1 gene from mitochondrial genome. Since many panel does not include mitochondrial genome, they need to be ordered separately, and these patients would have been missed if they were tested on panels. With that, I was able to show you what is the advantage and disadvantage of panel and exome testing. With that, I would like to end my presentation with proposed clinical practice using exome sequencing. This is what the current clinical practice looks like using a traditional sequencing. First, clinicians would have to examine the patient who are suspected of having a genetic disorder and note their phenotype. Then they review the patient and the patient's family history and run additional phenotyping to come up with a provisional diagnosis. Finally, physician would have to order a single gene test or gene panels that contains the gene of interest to confirm the diagnosis, of course. And this process does work actually pretty well for many diseases, such as Duchenne's muscular dystrophy or cystic fibrosis, with a specific set of symptoms that are both unique and have no genetic heterogeneity. However, for other heterogeneous disorder, oftentimes patients have to undergo a multiple panel test, resulting in extended time to diagnosis with increased medical cost. This is what we are proposing as genetic sequencing has become more affordable and readily available. First two steps are same, then physician alters an exome instead of trying to come up with a provisional diagnosis. Then guided by our exome test result, physicians performed additional phenotyping only when they are necessary. And implementing exome sequencing as a first-tier test will allow reduced time and cost to diagnosis and also allow patients to get more personalized clinical management. And thank you for listening to my talk. And I'm going to ask the same question that I asked in the start. Let's see. Here we go. What is not considered the advantage of panel sequencing have over exome sequencing? I'm gonna stop the polling here. Actually, the answer is C. Reanalysis can yield additional finding from novel gene. Like I said, most of the panels actually does not contain novel gene in their panels. Therefore, reanalysis of panel sequencing data will only yield reclassifications. Thank you.
Thank you to Dr. Seungwoo. We still have almost 10 minutes, maybe a little bit more than 5 minutes, if anybody has any question. Please feel free to ask. Okay.
No.
Yeah.
Thank you. I'm Dr. Christo from in Harmony, Jakarta. So you have stated the difference between panel and whole exome. What about the difference between whole exome and whole genome? What's the most important benefit, pros and cons between those two?
Let me show you. I actually prepared one of the slides for it. So this is diagnostic rate of individual diagnostic flow of rare disease patient in congenital pediatric disorders. As you can see here, whole exome sequencing has a diagnostic rate roughly around 26% to 30%, given or take number of different cohort and patient sizes. When you perform whole genome sequencing, this diagnostic rate does increase to about 40 to 45%. And main reason of this is because using whole genome, you can start to detect the variant in the intronic regions, as well as any structure variant apart from the copy number variants. So for example, whole genome sequencing can detect a copy number neutral variant, such as inversions or translocations. And also, like I said, it can also detect any regulatory element, deletion in regulatory element, as well as any single exonic deletions as well.
Then I also heard that the whole genome sequencing have different depth resolution, like VGS 30x, 100x. What about the whole exome?
So whole genome has usually average depth of 30, whereas whole exome has average depth of 100. It's actually the exome depth of coverage is high compared to whole genome because in order to cover every single targeted region to at least 20x, you need to increase the average into 100x because there is a difference in capturing efficiency within the human genome. But 30x, usually 20 to 30x, is enough to call out variant, either heterozygous or homozygous. That's why in the whole genome, the average depth of coverage is only 30x. But like I said, the mosaic variant is easier to detect if you have a higher depth of coverage. So therefore, if you're suspecting the patient has potentially have a mosaic variant, then performing whole exome is probably more preferred compared to whole genome.
So why are there VGS with 100x? Is it needed? Whole genome 100x?
For whole genome, you could increase the depth of coverage to 100x, but due to the cost, usually the diagnostic lab will only cover them by 30x. Because the number, as you know, the exome targets only 1% of the human genome, whereas whole genome will target the entire 100% of human genome. The data size is roughly 100 times higher. But many of the cancer patients, I believe, uses whole genome in higher average depth of coverage because many of the cancer patients have a somatic mosaic variant that can explain some of their cancer phenotypes.
Okay, maybe last question from the audience. Is there still any question? Okay, one more.
Thank you for the opportunity. My question is, if we send our samples to you, how long time we can take our result and how much does it cost?
Our TAT, I'd say, once the sample arrives in our lab, our TAT is 6 weeks to the reporting. However, this is just the maximum amount of time. Our reporting average is usually 4 weeks to 5 weeks. In terms of pricing, I can't really answer that question. You can talk to our sales representative here. She's our sales, senior business manager after the talk.
Yeah. Thank you.
Okay, thank you, and let's, one more? Okay, maybe one quick question.
Thank you so much. How about heterogeneity and cancer? Is also cover this to analyze, and how could you take the what? Apa itu? Yeah. Can you how can you detect this?
So in terms of cancer analysis, our company is currently not doing a cancer-specific gene analysis at this moment. If you are suspecting if your patient has a hereditary cancer syndrome, usually we can detect those kind of variants using whole exomes. However, if the patient is suspected of having non-hereditary cancer syndrome, just idiopathic that happened by somatic mosaicism, I would use some other company that targets the specific genes that are associated with the cancer in a higher average depth than usual clinical genome sequencing. Because most of the genetic tests that are offered by us are focused on germline variant, not a somatic mosaic variant. However, in that case, I would, for me as a medical geneticist, I would test the tissue, the DNA from the actual tissue, not a whole blood or buccal swab, and send it to the actual testing company.
Okay, thank you again, Dr. Song Ryu. The audience, maybe you can give a round of applause for our speaker today. Thank you very much. And of course, feel free to approach the representative from 3 Billion to ask more about the test after the workshop. Okay, next we will have the next session, session 3, featuring an interactive discussion on how do we know the pathogenic variants of cancer cases. We will have the facilitator for this session, Dr. Ahmad Utomo from Universitas Yarsi, and Prof. Dr. Sofia Mubarika from Universitas Gajah Mada. maybe both speakers, I invite you to the front of the stage, and also a short CV of both our speakers. Dr. Ahmad Rusdan Handoyo Utomo is a lecturer of Universitas Yarsi from the Biomedical Sciences Magister. He is also a member of National Committee of Stem Cell Therapy from the Ministry of Health and BGSI from Ministry of Health and Darmais Cancer Hospital. He is also senior consultants at Calgen Lab, CITO, and also Darmais Hospital. And his research interest is in genomic epigenomics profiling of breast, lung, and colorectal cancer. Professor Dr. Sofia Mubarika is a professor in histology and molecular biology, Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada, and she had been a lecturer since 1974, member of Indonesian Academy of Science and also Association of Indonesia's Stem Cell, and a leading researcher in cancer and Myrna. And to Pak Ahmad and Prof. Sofia, I give you the stage.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yeah, we will play duo with Dr. Ahmad. So I will have the task on viral oncogenesis on nasopharyngeal cancer, and Dr. Ahmad will do the genetic things. So why nasopharyngeal cancer is important in this afternoon session? Because so far this cancer is still set at the higher position in Indonesia, the fifth or the fourth among the top 10 of cancers, but also little of attention have been taken so far. So always breast cancer, cervical cancer, colorectal cancer, but nasopharyngeal cancer is a little bit neglected. So that's why this afternoon we would like to discuss with all of us to know a little bit more about nasopharyngeal cancer, and we will know if we don't know, and then we cannot understand why it's so difficult and it's still set at the high position in Indonesia. So I'm sorry if you cannot read the text, but nasopharyngeal cancer is quite unique cancer because the etiological factors is multifactorial. It's polygenic, of course. Cancer is polygenic disease, it's a genetic disease, but environmental, healthy lifestyle, diet, cultural, hygiene, pollution is also very important in this carcinogenesis. Besides also absolutely associated is Epstein-Barr virus infection. And also that latency protein and non-coding protein, non-coding RNA right now has been taken as an important factors that play a role in the interaction between genetic and epigenetic aberration in nasopharyngeal cancer that will affecting all of the hallmarks of nasopharyngeal cancer. So as I mentioned that nasopharyngeal cancer in male sit at the third here, according to Globocan 2018, and in female also 9 among 10 of the highest. And what we feel difficult is because besides multifactorial, Epstein-Barr virus and also human papillomavirus is also involved in this carcinogenesis. And also because of the location of the cancer, usually a patient come at the later stage. So that's why the patient become chemo and radio resistance, and also mortality rate is still high. So about 85% mortality rate among all of those cases. And what we also see here, that previously China sat at the highest rank of nasopharyngeal cancer, but now Indonesia is the third in Southeast Asian country, and China is already down at the lower position. Why? Because even though in southern part of China, the morbidity and mortality is still high, but because of changes of lifestyle and also advancement of healthcare facilities that make the morbidity and mortality is high. So we in Indonesia have to do a lot of research as well as a lot of action to work to decrease the number of nasopharyngeal cancer here. Because of it's infected in more than 90% population in the world, so Epstein-Barr virus is also named as a everybody virus. And it's different to coronavirus, hit and run. This Epstein-Barr virus is hit and stay. So it will infect the epithelial cells and also B cell, and then it will stay persistently. So it will stay dormantly at the B cell at the circular episome, and it will stay as a latency state. So this is the make the carcinogenicity of this NPC is quite high. And this ABV is associated with several cancers. It's not only nasopharyngeal cancer, but also Hodgkin lymphoma, B cell, and also stomach cancer, other head and neck cancer, because the transmission is so easy by saliva. So Epstein-Barr virus in the saliva will transmit to other population through water or through changing of things for the food. And the things that also very important that should be considered is a genetic susceptibility that will be discussed by Dr. Ahmad. According to life cycle, this virus infect epithelial cells in our oropharyngeal. This is as an entry point. And why this EBV can come into the epithelial? Because there is a receptor on this EBV. And then after infected, it will come to the epithelial cells. And then under the epithelial cell, the B cells also have these receptors on that viral cell, and this will infect B cell as well. The B cell become clonal expansion, and then if the immune system of the individual is adequate, that the CTL will destroy the infection. But if the B cell is still there, and then it become latency type, and it will circulate in the peripheral blood, become latency type 1 and type 2, and so it will, as a kind of reservoir, the B cell become the reservoir of the Epstein-Barr virus. And once the situation make it possible, the memory B cell in which the EBV reside will be reactivated, become plasma cells, and then it will make the virus in the cell, B cell become reactivated, replicate, become lytic action and lytic activation, and it will transmit via saliva. And this that are circulating in the blood can be detected through the antibody against that protein of the virus. For EPNA1 IgA or LMP1 IgA, and this then used as a serological test for the infection. Yeah. Now, with the more study on that mechanism of the Epstein-Barr virus, looking at the how that we can overcome this nasopharyngeal cancer, the signaling pathway are by the signaling pathway is aberrated because of the LMP1, LMP2, and EPNA1 is considered as an oncogenic part of the virus. And then in synergy with the Epstein-Barr virus non-coding RNA, those are regulating all the signaling of the cell-infected EBV become abnormal, included WNT signaling, JAK-STAT, P1-3 kinase, MAPK, and NF-kappa B that make the proliferation, stemness, and then metabolic reprogramming, all of the hallmarks of cancer become abnormal. So this is hallmark of cancer, of nasopharyngeal cancer, that people can understand that the phenotype, the phenotype activity of this hallmarks of cancer right now, already 14 hallmarks of cancer. And it appears that there is a synergy between protein, major protein of EBV with the microRNA of EBV with the microRNA of host infected. So this area have been interesting area of research right now, and people are doing a lot of analysis of this to understand more about the molecular pathogenesis, to be able to how to eliminate and how to stop the activity of the process. And quite interesting is about the predilection of the population and geography. Why China, north to south now increase, still high, but now it's being down the number, but still at the southern part is still high incidence, especially in the area of Cantonese. Still the average ASR as standard rate is still 24 point per 100,000 population, but yeah, but to the north part is getting decreasing. But this in America is quite rare, Canada also rare, but in local population like Inuit Canada is quite high, and also Alaska natives is quite high. So why? Yeah, Dr. Ahmad will explain afterward, yeah. And then how about in Southeast Asian countries? So unfortunately, Indonesia is the highest among others Southeast Asian countries. Still high, and also the mortality rate still about 85%. So a lot of effort have been conducted to stop the number, the decrease the mortality, and also how to detect through the early screening. So this is one of our, Dr. Dewi has been successfully, we have done a lot of research on nasopharyngeal cancer, and she has developed early screening strategy using EPNA1 VCAP18 IgG ELISA to do for early screening. And it has been make it more and more better, more precise, but still the PPV is not that high. So research also have been conducted by our team, and apparently that the combination of other DNA, like methylation or other genetic tests, are needed to improve the PPV, the positive predictive value of this EPV infection on NPC. So this is the some of the population-based screening has been conducted through methylations using 10 tumor suppressor genes with specificity and sensitivity. Yeah, you can see that, yeah, still sensitivity and specificity is not as that maximal. And then using EPV DNA from nasopharyngeal brushing, but unfortunately this is quite invasive, maybe a little bit of, yeah, not comfortable. Sensitivity and specificity is quite high, but again, yeah, because invasive. But how can we do more, less invasive or minimal invasive, such as using ELISA with serum? But the limitation is still sensitivity quite high, but PPV is low. Yeah, so that's why we have to do a lot of things together. Maybe Dr. Ahmad will explain about it later on. He's and the team also developed serological plus DNA of EPV. Come to the what we call it precision medicine. Now people also doing how we can do more specific biomarker to see from the clinical sites of NPC. So this is the biomarker radioresistance of NPC, even though it's still at the research level, but still some hope that optimistic that we are doing we will do and arrive there to contribute in more doing using molecular for clinical application. So this is the challenge right now, that we need early screening and prevention. Of course, changing in lifestyle, healthcare advancement, BPJS coverage for prevention. Now Dr. Ahmad will continue to explain about the genetic susceptibility. Please, Dr. Ahmad.
Thank you, Prof. Rika. Yes, Prof. Rika actually has explained very nicely the broad overview of a cancer that's actually ranked 4th in our country and probably in Southeast Asia, but not much talked about. Although we know some of the notable Ustad Arifin Ilham, he passed away, Allah yarham, because of this cancer. So, oh, thank you. Okay, so what I'm going to do is to highlight 3 topics, 3 subjects. Hopefully everybody would appreciate the challenges and probably opportunity as well in germline DNA testing. Like Dr. Ryu has mentioned earlier, he's doing lots of germline testing. I'm going to start dealing with cancer, but more specifically in nasopharyngeal cancer. Obviously, the question would be, who are at risk? Is everybody in the room have identical risk to get this particular cancer? Then, how it should be tested, and how we're going to do the interpretation of the genetic variants that we found in this NGS, for instance. Okay. So I apologize. Apparently, the text is a bit too small to see. What in this cartoon is basically trying to remind us that the nasopharyngeal cancer is basically induced by latent infection of EBV, like Prof. Rika has elaborated. And then the question would be, why certain people get higher risk than the others? Beside lifestyle, for example, consumption of, for example, this dried fish. We know in Indonesia we love ikan asin, yeah. Okay, but I don't want you to stop eating ikan asin because it's high protein as well. But just be aware that you have to have a very wholesome nutrition. Now, the interesting part is about HLA polymorphism. I want to spend a little bit time about HLA. Everybody born with different and unique HLA variants. That's why when we want to do transplant, you have to match it. Okay, most likely if you just take it randomly, you're going to get a bad rejection. Now, why is HL is very important when it comes to viral infection? If you notice in COVID, you heard somebody, they've been taking care of COVID patients, their family members have been sick, but they never got sick. And people were wondering why he got some immunity without even exposed to vaccine. So apparently we have to understand, if this cartoon on the right side, I guess on my right, you see that's actually very busy molecules. Just focus on the red one, okay? Think of HLA, human leukocyte antigen, as a cup, okay? This cup is actually on top of the surface of our cell. What is function of this cup? The cup will present any antigen or any peptides the cells produced. So for example, when you infected with the virus will have some proteins translated in our cells, then parts and bits of these proteins, or we call peptide, will be presented by our HLA, right? Okay. So the thing is, this variant of HLA is going to create some variation in how well it fit this peptide to this HLA. If it fits very well, it's going to present also very well to our immune system. So your immune system can actually recognize and kill the infected cells. So just imagine if you have a very lousy cup and it cannot hold the peptide very well, then it may give an impression there is no virus infecting your cells, but actually there is. So if this is the case, then it may explain why certain variants of HLA actually create some susceptibility or even protection. So if you look at this forest plot, what it's saying is that this HLA is in the bottom half of the table. If you look at the right, those people are actually higher risk to get NPC. If you're going to the left, it's more protected. However, the odds ratio is a bit modest. It's about 2 or 3 times. And generally, if you compare to smoking, that could be about 40 times. So I mean, so I always tell our students, when it comes to statistical values, you have to put in context. It could be statistically significant, but it may not be, within quotes, real life significance. Sometimes students are really opinionated or very passionate to get p-values, but don't worry about the p-values. You have to be understanding in context. Okay, so when it comes to HLA, definitely there's a germline. It's a germline variance, okay? And we also know that some cancer mutations, not only germline, but also somatic, like Dr. Yu has mentioned earlier. I'm not going to talk about that somatic one. It's a bit more complicated. But my question would be, would that be any other germline variation that render individual has actually a higher risk, or importantly, extremely high risk to getting cancer? So this is actually a very simple depiction. How are you going to explain penetrance? When it comes to penetrance, think of your ABO blood type. When somebody got a B blood type, that means she has actually a gene encoding a B type. And most likely, close to 100%, if you have a gene of a B type, you're going to get a blood O, you're going to blood B, not a blood O, not a blood A. Okay. So similarly, if you have a gene to encode for a blue eyes, you're going to get the blue eyes. You don't get the brown ones. Okay. That's called 100% penetrance. When it comes to genetics of cancer, you never tell you 100%, except maybe retinoblastoma, close to maybe 90%. But other than that, it's very rare you can get. So that's why you don't say, I'm getting this cancer genes, I'm going to get 100% cancer, what's going on? No, it's not true. When it comes to cancer, you generally get the risk is about 60 or 70%. So how you want to read this table or this graph? The more you go to the right, that means the variance is very common. HLA is very common variance. So that's why the effect size to get cancer is generally modest. It could be statistically significant, but not significant enough to maybe give some specific intervention. So this is why, for example, when you get, say, BRCA mutations in case of hereditary breast or ovarian cancer, or when you get the Lynch syndrome panel mutations, the intervention could be very, very specific. You're going to get early screening as early as 25 years old. But when it comes to low penetrance genes, where there's a modest risk, then you probably end up saying, okay, then you have to stay away from smoking, do some sports, eat well, food. But if that's the case, then what's the point of genetic testing, right? I mean, this kind of issue has always been lingering. So I myself has been actually quite interested in the high penetrance ones. That is, the variant is quite rare, but if you get it, then you can say, or you can actually give some recommendation, a very specific one. So if you look at the left, we talk about a very rare variants, but the impact, it is very high. This is called the high penetrance genes. So in the high penetrance genes could be BRCA1, BRCA2, MLH1, MISH2, all the Lynch panel syndrome, P53. If you look at the Li-Fraumeni syndrome, all these syndromes you don't have to memorize, but it's all there. Okay. Now, this is actually the interesting part. When it comes to familial nasopharyngeal carcinoma, first of all, in Indonesia, the infection of EBV is very common, but obviously not everybody getting NPC, right? Okay. So apparently there are cases where in a family, not only one patient of NPC, but 2 or 3 or 4 cases of NPC in the immediate family. So this is what we call familial cancer. Although we know technically there's a difference between hereditary and familial. But for argument's sake for today, let's call them familial type of cancer. So when it comes to this familial type of cancer, what they did, this is actually a Taiwanese studies, they recruited about 502 familial NPC cases. There's a lot of numbers. And the control is about 328 healthy controls, right? And then they're gonna they look for whether there are variants in a germline. So they take a look at the blood and then run the NGS. And this was interesting. Apparently, one of the gene that seems to be found germline, that means they are born with this variants. There is actually BRCA1. Now, you generally don't associate BRCA1 with NPCs, right? And this could be very interesting if we can look at these patients, whether they did have actually family history in breast or in ovarian cancer. So if this is the case, how are you going to counsel the family and family members? Are you going to say, wait a minute, we are having NPCs, now you're telling me you're coming back with the BRCA gene. So this could be interesting. But the point is, apparently, for some patients who are actually at the elevated risk, maybe in their genome, they have some problems. Because what we know, BRCA is a DNA repair gene. It's DNA repair proteins. And we know EBV doesn't cause mutations. When EBV actually infected the cells, it generates some maybe immune response, but generally doesn't really cause the mutation itself. It may actually induce some reaction. But when it comes to BRCA, which is actually a DNA repair, and also ERCC2, which is also another DNA repair mechanism, it may explain there is some inherent genomic instability that cause the individuals getting high risk of cancer. And if it's added to it, EBV infection, a latent infection, that may actually explain they have a higher risk of NPC. So what I'm going to do, the last topic, hopefully we have time, and I think our friends just give you the QR code for the quiz. Okay, at the end of my talk, then you may fill up the only 2 questions, and Prof. Rika and I are going to comment on your answers. So what is this ACMG? ACMG is American College of Medical Genetics. It's actually just published a guideline how to interpret genetic variants. However, when I say interpret, I'm not genetic counselors, so I have no authority to actually communicate to patients what these variants mean. This basically more of the people like molecular biologists, cell biologists who are interested, or geneticists who are interested to find out whether the variant's actually pathogenic or benign, or of unknown, we don't know the significance. We call it the VUS. This guideline published by ACMG is very timely because in Indonesia, we know our Ministry of Health aimed to sequence 10,000 subjects within 2 years in 9 different diseases. So the question is, when the patients come up with these variants out of the NGS, we don't want the clinicians get confused. Or even the patient got confused. What does it mean? We have so many variants. Which one is meaningful? Which one I can just throw it off, or something that I have to take it seriously? So this is a very busy slide. I don't want you to memorize all that. It's all in the internet. But the reason ACMG creating this criteria is basically trying to look at different parameters, what kind of data you need to get in order to make a good interpretation. So if you can imagine the box actually divided into two parts, the past two-thirds will be on the right. Those are what we call the pathogenic ones, something that is taken seriously. But on the last one-third to the left, that's what we call the benign one. Benign one, basically, of course, we are not clones, we are different. So the variant is just basically being normal. I'm going to just give you an idea, only 3 parameters. We have so many parameters, but I'm going to focus only on 3. When this 3 is actually found, it may actually incline the variants being pathogenic. First one. The first one is about how frequent the variants found in the population. So what the Ministry of Health is doing with 10,000 people, although it's not that many, you know, compared to UK Biobank, maybe hundreds of thousands, maybe millions. I don't know, in Korea probably it's even more with the Korean Genomic Initiative. How many? Over 50,000. So we just started, okay? So at least we start knowing how frequent the variants of interest in our population. Remember, this cancer is not that frequent, okay? That's why, in a way, if you compare to diabetes, hypertension, heart disease, cancer is a bit in the modest numbers, but it's catastrophic. That's why BPJS say that the cost of cancer patients is close to heart patients, although the numbers actually is less. So that's why we have to know how frequent is the variance found in the population. If the variance seems to be more than, say, 1%, more than 5%, in a way, I personally would dismiss that as being not playing a role in a high penetrance genes. So the idea is very simple. Just remember, you have a control, you have a cases. If the variance is very common in control, control means what? Control means the healthy ones. And of course, ideally, the controls have to be adjusted with age, okay? And there's no disease found in control. And if it turns out to be very common, then we can tell that it may not be important ones to lead to the high risk. Second, then we have to look at the literature and ask whether the variants of interest that we found in the patient has been tested in vitro and whether actually cause the loss of function in our gene of interest. So for example, if the gene is found, say BRCA1, we found this variants, we tried to look at the literatures whether this variant actually caused loss of function in the BRCA1 gene. So that's actually the second one. And the last one, again, we have to look at studies, at different literatures, and ask whether the variants that found in this particular one has been described in a co-segregation studies. What co-segregation? So you have to look at families with a large number of members of family, and then you can track which family members got cancer, which family members get no cancer. And then if the genetic variants always follow with the cases one, with the affected ones, then you say these are very important ones because it always segregate with the disease. So all this data, it's based on internet. And the problem is some DNA company like Myriad Genetics, they don't share. They don't share the data. So I always ask Dr. Ryu, you're going to share the raw data with us, you know, because for academics it's very important. Not just service, okay, the patient get a diagnosis, but for scientists like us, for researchers, we want to know whether we can analyze further. Okay, in summary, so NPC definitely remains a top 4 cancer in Indonesia with high rate of mortality, and it's very surprising we don't have an established regime how to screen this cancer. In cervical cancer, we have DNA testing, DNA HPV testing, pap smear. Lung cancer, we have low-dose CT. But in NPC, we don't have it yet. But the promising one, serology screening, like Prof. Rika and her team in Jogja, they start developing this, and hopefully we can combine with the genetic testing in order to improve early detection of NPC. Although currently there is no established genetic testing, what the recent papers show you, it may be interested to look at certain cases where certain family have elevated risk of cancer based on their genetic variants found in their blood. But the question is, who is the individuals to be tested? So currently, it would be interesting if you look at the history, if they have actually multiple family in the family got the same cancer. And last, in order to make a critical definition of whether this variance is pathogenic or not, meaning there's some clinical meaning for the patient and their families, there are three things. Look at the frequency in the general population, look at the evidence of functional assay in vitro, and look at the co-segregation of the variance in the family in the literatures. So I'll stop here, and I would ask the our committee to show. But hopefully everybody already put the quiz. Is it there? Okay, let's take a look. After we are discussing the, okay, so this is actually the QR code. Please scan it, and there are only 2 questions. I always tell my students, I do this all the time in my lectures, to encourage them to participate. Don't worry about grades. It's better to get bad grades but you understand what you're doing, rather than having a good grades but you got no idea why it is right. So we're going to discuss your choices. We appreciate our previous facilitators and experts to discuss why this is the correct or maybe the ideal answers. Okay, do we have the data? Okay. Baik, terima kasih atas, thank you for your response. Sorry for our friends. Okay, so, could you make it a bigger screen, please? Yeah, you can reboot now. Okay, this is fine. So Mr. X, a healthy male, age 35 years old, shares his concern about getting cancer because his older brother, age 45 years old, and his uncle, age 50 years old, had, the story is a bit long. So basically, will you recommend the test? Okay, this the data, Prof. Rika. No need to screen, there's the least one, about 1%. No need to test because NGS is performing germline testing from blood, while NPC we know is mostly somatic because of the infection. Rapid test screening using anti-IgA, Prof, is about 12%, and the majority suggest that they recommend NGS using blood sample because there is an indication of familial cases. Would you like to comment, Prof? Any comment? No? Okay. Yeah. So when it comes to NGS, definitely the issue is cost. Okay. Now, if you want to screen Indonesian or Southeast Asia, who's going to pay? But everybody say using NGS, but from the serology test, how much the cost, Prof? Is it cheaper, right? It's very cheaper. How much, Prof? Spill. 50,000. 50,000 rupiah. That means how many $5? $5. Your NGS, how much? No, I'm saying it. Definitely not the $5. Definitely not $5. So this is actually an issue when it comes to public health. I remember in UGM when Dr. Samuel Haryono was actually tested in UGM in Gajah Mada. I remember the examiner asked, Dr. Haryono, if you have 200 million rupiah, will you spend it on screening for cervical cancer or to run NGS to look for BRCA1? So I myself would think of recommending the NGS test, me being a researcher, but a public health colleague probably will go against it, right? So that's why when we look at the NGS, we have to be very careful who you recommend. So of course, in this case, there's an indication of high numbers of family. So you don't screen everybody. So what I want to say from the last choice, don't go out, recommend everybody to do NGS. That's what my point is. But unless and until you have a good, strong indications, yes, it could be. NGS just like a tool. But unless NGS becoming 50 rupiah, 50 ribu, yeah, until NGS becoming $5, then everybody can test. You agree? Okay. All right, thank you for the response. Okay, next one. Okay. All right. So, this is interesting. So the result coming back, ERCC2 gene with so and so. Okay. You have to understand when it comes to genetic variants, there's always the possibility the variance result is what we call VUS, variant of unknown significance. Clinicians hated it, you know. What do you mean of unknown significance? We pay millions rupiah, you know, not 50,000 rupiah, yeah, millions rupiah, and you're telling me with this thick papers printed is unknown significance? And that's actually the reason we're doing NGS. The problem with doing NGS, the more data you generate, the more unknown significance you're going to get, right? Okay, so that's why don't get surprised when the result is unknown significance. Okay, and why is that? The reason being because, for example, we look at the data, it's not found in population. So I want to give a little bit information about population. In Indonesia, sometimes we think like this. Oh, this gene is very new. Or, oh, this gene may affect the Caucasian but not the Indonesians. my first response would be, as long as we are Homo sapiens, we should get the same response. Because we are Homo sapiens. Unless we are complete Neanderthals or Denisovans, that's something else, okay? But as long as we are Homo sapiens, it should be the same. The frequency could be different, okay? I'm not saying that ethnicity is not important, but when it comes to biological or biomedical, the biochemical mechanism should be the same. BRCA1, if it's the same variant, it's going to create the same function, but the frequency will be different, okay? So if you look at the population and you see, okay, this variant has been not found in any population in the world, in Asia, Africa, Caucasians, not found anywhere. That could be an indication that it's probably pathogenic, but by itself, it's not sufficient to say it is pathogenic. Do you get my GIF here? Okay, yeah. So you have to look also again whether it's the second data, like what I said earlier, any functional data or not. So then you have to look at the literature. So that's why if you want to be good at this, you have to be familiar with databases, okay? And find these literatures. The fourth one is interesting because it only changes an amino acid from alanine to threonine. This is actually another difficult part in interpreting variants. Whether the single amino acid is important or not. It could be important, okay? For example, in drug dose pharmacogenomics, this single amino acid change could be very important. But when it comes to cancer, this is the most difficult one. That's why when the changes, we call it SNV, single nucleotide variants, is much more difficult than, say, deletions or insertion or higher copy numbers. So if that's the case, we cannot just say, dismiss it, it must be benign. No, you have to also look at the other data, functional data, frequency, and also co-segregation analysis. Okay, yeah, I think that's probably it. Okay, we have left about 5 minutes. Anybody would like ask Prof. Rika or me to clarify dissenting opinions? Because we just go to the Mahkamah Konstitusi, yeah? But apparently everybody agree here. So, any questions? Oh, thank you for your participation. Yes. Oh, yes. Okay, please.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
I'm a student of the biomedical science. I don't know, maybe this question will be for Prof. Mubarika or Pak Ahmad, but from those all lecture, I understand that the early detection of the nasopharyngeal cancer is important. So why is that? I mean, is it for the prognostic reason or for, I think. Thank you. It's a simple question.
Okay, what is the question again? Sorry?
Sorry?
The importance, yeah?
Early detection.
Oh, okay.
Yeah, because I understand that the University of Gajah Mada developed a kit for the detection. Yeah. Thank you.
Excuse me, namanya siapa? Terima kasih, Dr. Erlin. Ya, terima kasih. Thank you for the question. Why early detection is important? Yes, unfortunately for nasopharyngeal cancer, because the location of the cancer is hard. Even the doctor, the medical doctor, yeah, the medical doctor sometimes has difficulty in finding the location of the nasopharynx. So because the location is behind the at the area of behind the nasal and pharynx. So because of the location first. The second, the symptom is also not specific. So usually patient come not because of something, but because of runny nose or something, something happened in the ear, the function of the ear, deafness, and then also from the eye. So that's why most of the patient come at the late stage. So that's why the therapy, clinician chemotherapy and radiotherapy become not satisfactory. So that's why early detection is considered very important. And the first and the easiest things to be done for the community is using the serological, because the Epstein-Barr virus is persistent in the body. It is reside in the cytoplasm of B cell as a circular form. So that's why the antibody against this latent protein is appear in the blood. So that's why the simple thing that we can do is using the serological test. So that's we think about the making the early detection will help to detect earlier. And so far, this early detection have been screened to also to healthy people. And in these healthy people, we have got several are positive. And also they found still at the young stage, so that's young age. So that's why this is showing that this result is quite important to be considered for early detection. Yeah, thank you.
Thank you, Prof. Rika. Maybe just to add another aspect of the demography, why it is important, Prof. The patients of NPC generally are quite young. Right, Prof? Yeah, around 50, 40 to 50 maybe?
Even 11 years old.
Oh, even 11 years old.
Even still
so for our population where the young people are still very productive, they are contributing to the economy, definitely there is actually the need to really identify which one will get the nasopharyngeal cancer or at risk, at higher risk. So for instance, when they have something, sinusitis or something like that, they may have to take it more seriously, because the impact, the economic impact of affecting these young people, especially males, because generally males or female,
both.
Oh, both,
but male is more,
Oh, okay. So both male and female, but male slightly higher. So if you know, males generally the breadwinners. So these kind of things that we also should take into consideration why it is important. Then, unlike lung cancer, which you could maybe drop it to very shortly by smoking cessation, with NPC we don't have what would be something we can change in order to really suppress the rates of carcinogenesis. Generally, we should expect elimination of lung cancer by banning cigarette. But cigarette, the tax income is so that's why the government seems to be, they're kind of wishy-washy when it comes to cigarette ban. So maybe just to add, why this is quite important. Yeah. Anybody else, maybe? Should be okay. If it's no other question, I'll turn it to Prof. Rika, Prof, as moderator for the next session. Yeah.
Thank you so much, Dr. Ahmad. Thank you for the attention for this session. We'll continue for the next session. Yeah, there will be 3 speakers in this session. The first is Professor Dr. Zilfalil Alwi, MBBS, MMed, MSc, PhD, FAMM. And then Professor Dr. Narazah Muhammad Yusuf, may I call them? Yeah. Please come forward, please be seated. And then Dr. Anggraini Iriani, Spesialis Patologi Klinik Konsultan. Prof. Zilfalil, excuse me, if I may, I would like to read your CV, but there will be a pre-test first. So before your presentation, there will be a pre-test first. Yeah, okay, please have a seat first. Yeah, I would like to introduce Professor Dr. Zilfalil Alwi. Professor Zilfalil is the UNESCO Chair on human genetics of thalassemia and a member of the World Health Organization Technical Advisory Group on Genomics. He is a senior consultant, pediatrician, and clinical geneticist at the Human Genome Center, School of Medical Sciences, University Sains Malaysia, Kota Baru, Malaysia. And Professor Zilvalis is the founder and head of the Malaysian node of the Human Variome Project. He is a member of the board of directors of Human Variome Project International and the joint chairman for Global Network, Globin Network, a global project by HVP which involves the systematic collection and sharing of variation data to combat hemoglobinopathies. He also member of the Scientific Advisory Committee and the Gene Disease Specific Database Advisory Council of Human Genome Organization, HUGO, and the chair of the Genetic Counseling Subcommittee of the HUGO Education Committee. Welcome, Dr. Prof. Zilvalil. And then secondly, I would like to invite Professor Dr. Narazah Muhammad Yusuf. She already visited in front, MBBS, DCP, MSc, PhD. Professor Nazarah Muhammad Yusuf is a consultant hematopathologist at Advanced Medical and Dental Institute, MDI, University Sains Malaysia. She graduated from the University of Malaya with MBBS and obtained her postgraduate degree from the University of London in Master Medical Science in Hematology. Her PhD was from Kobe University Graduate School of Medicine, Kobe, Japan. Her research interests include molecular hematology and clinical transfusion. She has published so many papers in peer-reviewed journals and also graduated PhD and master students in her field. And internationally, she has been appointed as a visiting professor at Newcastle University, UK, research consultant at Xinjiang Medical University, Xinjiang, China, and adjunct professor at Erlangga University, Surabaya, Indonesia. Thank you, Professor Narazah. And then thirdly, I would like to invite Dr. Anggraini Iriani, specialist pathology clinic consultant, hematology consultant, CS hematology consultant, PhD medical at Medical Faculty University of Indonesia in 2018, clinical pathology specialistic doctor from UI, medical doctor from Andalas University. Currently, she is a lecturer at Clinical Pathology Department, Faculty of Medicine, YARSI, head of the Department of Clinical Pathology, Faculty of Medicine, YARSI University, head of Molecular Genomic, YARSI Hospital, head of Infection Control Committee, YARSI Hospital, and actively in research in hematology, oncology, and immunology. Dr. Anggraini, yeah. Please, now, pre-test first, yeah. Pre-test first, and then Prof. Zilvalil.
For the participant, the quiz is about 2 minutes. Sorry, Prof. Maybe we end it.
Okay,
with,
thank you very
and
much.
you can
And
continue.
now time for the presentation. Each speaker will have about 15 minutes in total, 1 hour, and then the 5 minutes for discussion. Is that correct? Yeah. Okay, please, Prof. Sival.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. This is fine. Thank you. Thank you very much, my dear friend, Professor Sofia Mubarika. Siap. So it's good to be back in Jakarta. The last time I visited Jakarta was many years ago, way before COVID. And it was totally different at that time, but this is my first visit to ERC University. So I must say that I'm very impressed with ERC University. My first impression was ERC University was a small place, but when I arrived, I was very surprised to see that, it's a huge place. In fact, it's bigger than my campus in Kota Baru, Kelantan. So I'm so happy to be here, and thank you for inviting me and also to share with you my experience. And I must admit that this is my first experience using Menti. So I have no experience using Menti, but this is also a new format for me, the way, to teach in a workshop. But I like it, and I hope I will be able to use this in Malaysia and Menti. So I will be very quick. The organizers told me only 10 slides, but I have 25 slides. So, but I will be very quick. My topic is on thalassemia, it's not moving. Okay. So thalassemia is a form of hemoglobinopathies. So it's a group of inherited blood disorders and characterized by abnormal hemoglobin production. So the key word here is inherited. And I think thalassemia, hemoglobinopathies can be found all over the world and has become a global health burden. Also, I think, in this region, in Malaysia as well as in Indonesia. And the most common form of hemoglobinopathies are thalassemia and sickle cell disease. But today, I will focus just on thalassemia because it is, I think, very common in Indonesia as well as in Malaysia. So like I mentioned earlier, thalassemia has become a global disease, especially it affects mainly the low and middle income countries. And I will show you later the reason why these countries, unfortunately, has been very much affected. So it is an inherited disease, and the mode of inheritance is autosomal recessive. And from the earlier slides, the earlier lectures we heard this morning, I think it's quite easy to diagnose autosomal recessive disorders. So when you see, you just need to identify the carriers, and then, if the disease appears to affect just one generation and affects both male and female, I think most likely it would be an autosomal recessive disease. So thalassemia affects regions or countries where malaria is endemic. So the reason for this is in regions where malaria is endemic, the people there will try to evolve so that they can fight the malaria infection. And as we know, the malaria parasite injected by the mosquito, it will invade the patient's bloodstream and goes and multiply in the red blood cell. So without a good red blood cell, it will not be able to multiply. So in order to survive, man changes their red blood cell to make it fragile, so that the malaria parasite will not be able to grow within the red blood cell. So this has saved them from malaria. However, it has created a new disease, the hemoglobinopathies and thalassemia. So if you see the region where malaria is common, those are the same region where thalassemia and hemoglobinopathies are also common. And unfortunately, these are also the region where the countries, the low and middle income countries are located at. So to treat thalassemia, it costs a lot of money. But unfortunately, if it affects low and middle income country or low income country, the cost for the government is huge. So thalassemia patients in these countries tend to suffer. They do not get optimal care because most of the budget or the funding will go to other diseases, but not to thalassemia. So basically, thalassemia can be divided into alpha and beta depending on the chain, the beta chain or the alpha chain of the hemoglobin, which one is affected. So for the alpha thalassemia, it affects mainly the alpha 1 and alpha 2 genes, which is located on chromosome 16. And for beta thalassemia, it affects the beta globin gene, or the HBB, which is located in chromosome 11. So how thalassemia is inherited, I think this is obvious. I think most of you are genetic counselors. You are well aware of this. Alpha thalassemia can be divided into the one gene deletion, which is called the silent carrier. And those individuals affected by a single gene disorder or single gene alpha thalassemia tends to, the offspring, 50% of the offspring tends to be, affected or become a carrier as well. And the other 50% are normal. However, with remaining 3 functioning alpha gene, it causes no symptom because this is sufficient, to provide, to live up to the needs of the requirement for the patient. Now, if there's a 2 gene deletion, the risk to the offspring, will increase, and it will affect. All the offspring where all of them will be carrier. And this is called alpha thalassemia trait. And for 3 gene deletion, which is called hemoglobin H, the offspring tend to be affected either by a single gene deletion or a double gene deletion or 2 gene deletion. And of course, alpha thalassemia major or 4-gene deletion is fatal, and most of the time it results in death of the baby or hydrops fetalis. So what we need to remember is how this one gene, 2-gene, or 3-gene, or 4-gene deletion affects clinically. As I mentioned earlier, 1-gene deletion, basically the patient is normal, not affected at all. And 2-gene deletion, the patient tends to have just mild anemia. 3-gene deletion, they tend to have a moderate anemia, and sometimes it can lead to severe anemia and maybe blood transfusion dependent. And 4G deletion is fatal. But for beta thalassemia, I think it's more straightforward. You can either have one copy of the gene being mutated, and the other copy normal, and of course the risk to the offspring would be just 50% being a carrier. And of course, if you have 2 copies of the gene affected, it can either result in moderate to severe anemia. If it is just moderate anemia, we call that thalassemia intermedia, clinically thalassemia intermedia. And if it is severe, we call that thalassemia major. So how do we diagnose thalassemia? So it's important that all patients get, first as a first line, the hematological test. Also, the second line would be the molecular test, which is considered in many instances to be confirmatory. Now, hematological investigations include a full blood count or full blood picture, HB analysis, and HBH inclusion test for the alpha thalassemia. And of course, the confirmatory test is molecular study. So basically, the primary hematological test, as I mentioned earlier, would look, we have to do a full blood picture and look for the MCV, MCH value. From there, we can proceed with HB electrophoresis or HB analysis once we have ruled out iron deficiency anemia. And some of the form of thalassemia, beta thalassemia, and alpha thalassemia especially, would be required to do a molecular analysis. So in most hospitals, you see that for the diagnosis of thalassemia, 2 labs will be involved, the hematology lab and also the genetic lab. But some centers which are more established, which have a thalassemia center, they tend to have a combined lab, both hematology as well as a genetic laboratory. And in fact, I think in many countries now, most of the hematology lab would also have a molecular unit within their hematology lab. So when to proceed for a molecular test? Those are the situations listed there. But I'd just like to highlight about prenatal diagnosis as well as genetic counseling, where I think molecular tests or molecular information of the patient is necessary to provide an effective genetic counseling as well as prenatal diagnosis. So I will not go into detail regarding the tests that we can do for the beta thalassemia as well as alpha thalassemia, but I would just like to mention about the common tests that we do to diagnose beta thalassemia in Malaysia and also believe in Indonesia. And for alpha thalassemia, the GAP PCR. And for beta thalassemia is the MUMS PCR or the multiplex amplification PCR. So MUMS PCR is used by most hospitals in Malaysia to diagnose beta thalassemia. So it involves 5 different multiplex arm PCR panel plus 1 single arms PCR reaction. So in total, there's 6 panels as listed there. And they are able to detect, from these 6 different panels, they are able to detect a total of 20 mutations. So these are the list of mutations which are most common in Malaysia. And I believe, as I've spoken earlier to the colleagues from Cirebon, is also among the mutations which are also common in Indonesia. So I think MUMS PCR is cheap, relatively cheap, most of the labs, the genetics lab, in many hospitals will be able to carry out this test. And of course, I think now there are also newer tests, including those using the NGS panel sequencing. But I won't go into detail for that in view of time. This is my last slide. So I'd just like to mention about for alpha thalassemia, one of the most or the primary tests that is being used is the GAP PCR, where this is a rapid, a simple, and non-radioactive method that allows the identification of the large deletion that we see in alpha thalassemia. So this is also, I think, most of the genetics lab will be able to use GAP PCR for the diagnosis of alpha thalassemia. So these are the two, I think, primary tests which can be done in many genetics lab and help to diagnose thalassemia. So I think that's my last slide. Thank you very much. And I'd just like to add that thalassemia being common in Southeast Asia, especially Malaysia, Indonesia, I think deserve more attention than what it has received by now. More attention by everyone, especially the government, the policymakers. Thank you very much.
Very much, Professor Zilfalil. Please be seated. We will have the discussion for question and later, yeah? And then I would like to invite Dr. Professor Nazara for 15 minutes for you.
Just bear with me for a couple of minutes. Okay, sorry about that. Right, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon to everybody. So the discussion that we're going to have now is about diagnosis and clinical manifestation of G6PD deficiency. So these are the topics that we are going to cover today, including introduction, epidemiology, variation in disease severity, clinical manifestations, diagnostic evaluation, and differential diagnosis, focusing on the clinical manifestation and how to make a diagnosis in this challenging, well, quite a challenging disease. All right, we know that G6PD is a sex-linked, inherited, and traditionally, we always think that the red blood cell only is involved. But a lot of studies have shown that G6PD deficiency also affect not only the red blood cells, but other cells of the body, for example, white blood cells, platelets, and other somatic cells. Being a ubiquitous enzyme, this enzyme is present in all the cells of the body. All right? The main function of this enzyme is to generate NADPH, which protects the red blood cell from oxidative injury. We know that this is the most common enzymatic disorder of red blood cells. About 400 million people are affected globally, and a very significant presentation of this disorder is that manifestations are variable from an individual to another individual. All right, so G6PD enzyme is critical for life, all right? And as I said, it produces NADPH. This is important to maintain the homeostasis. And we also know currently that enough G6PD is also necessary for normal growth and organism survival, all right? And current studies have also noted that this enzyme is very important in the embryogenesis. If you compare the prevalence of G6PD deficiency and thalassemia, it actually is distributed along the same tropical and subtropical region. In Malaysia, we have implemented newborn screening since 1982, and we have come to a figure that the incidence is 3.2%. So why do we have a variation in the disease severity? We know that this is an X-linked disorder, and usually the males are affected, but mind you, the females also can be affected, especially when they inherit a heterozygous G6PD mutation. And we always say that females are unaffected carriers, but they may be affected as well. So up to now, over 200 G6PD variants have been described at the biochemical level, and at the genetic level, there are about 150 mutations recorded. And the biochemical variants are classified, have already been classified by WHO into 5 classes. And this classification is based on the magnitude of hemolysis upon oxidative stress. So these are the mutations that have been described. Commonly, patients are found to have single missense mutations. But a portion of the patients actually are also found to have multiple missense mutations, all right? So there are 15 missense mutations found in patients, And these missense mutations are especially prevalent in areas where G6PD is common, as we are going to see in our patient as a case study afterwards. All right, we know that the clinical manifestation is mainly due to the deficiency of the enzyme in the red blood cell, and the red blood cell will have hemolysis. The patients will come with hemolytic disorder or hemolytic manifestations. For example, they are anemic, they are jaundice, they may have dark-colored urine, and the significant presentation is usually they are asymptomatic. But once they are exposed to oxidative agents, for example, they eat certain kind of beans, that is fava beans, or they are exposed to infection, they are prone to hemolysis. Okay, so this is the manifestations. The pathogenesis is the red blood cells will be removed by the macrophages, and they form bite cells. This is the traditional way of diagnosing G6PD deficiency on the peripheral blood film. You know, you see the blister cells or the ghost cells as shown by the arrow, all right? But these ghost cells disappear after 24 hours. And these are some of the symptoms developed only in specific age group. For example, if you look at the bottom of the pyramid, most of the patients have anemia, reticulocytosis, and raised serum bilirubin. And at the top of the pyramid are the infants. Usually they will present with deaf or systolic murmur. So for the diagnostic evaluation, indications for evaluation or testing for this enzyme deficiency So we don't screen all patients for G6PD deficiency. Okay, not all countries screen for this deficiency in the newborn, all right? So let's say if you want to evaluate potential or suspected patients for diagnostic evaluation, so these are the recommended groups of patients that you want to evaluate, all right? So evaluation of neonatal jaundice, or unexplained hemolytic anemia, asymptomatic individuals at high risk of G6PD deficiency prior to administration of certain medications, and other populations, for example, for newborn screening, or asymptomatic family members of affected individuals. And testing may be performed using an initial screening test followed by a confirmatory test. And at some centers, a confirmatory test is done initially. So it depends on the available resources. So for screening tests, we use a fluorescent spot test or fluorescent screening spot test. You can proceed to enzyme assay for confirmatory tests, and some centers will use molecular analysis. So there's also a point of care test which is under investigation. And what about the role of population screening, whether we want to test for patients where this G6PD is prevalent? But as mentioned earlier, newborn screening is done, but this is just screening, and screening has its challenges and limitations as well. So this is the algorithm. The reason I show this slide here is because there is a condition called acquired G6PD deficiency, all right? And this acquired G6PD deficiency is usually associated with diabetes or other endocrine disorders, and the patients may present as acute hemolysis, all right? But luckily, the symptoms will disappear upon treatment of the disease. So pertaining to the diagnosis and its challenges, as mentioned earlier, the screening test is inexpensive, easy, but the challenge is only able to detect only 20% or less, all right? The quantitative assay test is accurate, sensitive, all right? But in hemolytic anemia, in acute hemolytic anemia where the retics is high, this can be challenging, all right? And of course, we can do Sanger sequencing, all right? And we are talking about NGS, okay? So a differential diagnosis include other inherited hemolytic anemias, acquired hemolytic anemias, and conditions causing neonatal jaundice. All right, so for the clinical case study, we have had a patient who is a 30-year-old Chinese lady, all right? Her reticulocytes was 2.7%. She came to the hospital. She was pregnant that time at 28 weeks. And she was noted to have chronic anemia since the age of 10 years old. But it was not properly adequately investigated. On arrival, she was noted to have mild anemia with the MCV increase, that means macrocytic anemia, all right? And then her assay was low. The father also, family history, the father has had mild anemia, but her 3 other siblings have normal hemoglobin. And since this patient actually was seen at a private hospital, and well, currently in Malaysia, if you want to do sophisticated and expensive tests like NGS, usually you have that in the private hospital where the patient has to pay, all right? So for this patient, her sample was sent for NGS analysis, all right? And the panel for hemolytic anemia was done as well. And eventually, the results showed that she is heterozygous for 2 missense mutations, which is mutation 1388, which is G6PD Kaiping, and 1376. And both these mutations are pathogenic, all right? So what happened to the patient is that it was noted, the results showed that she has these 2 mutations, but on the trans chromosome. That's why the symptoms were not severe. If the 2 mutations were on the cis chromosome, all right, so the mutation, the manifestation may be severe and significant, all right? So this shows NGS actually can evaluate whether the mutation is on the cis or on the trans, all right? And also, you know, we know that females, they have X inactivation as well, all right? So eventually the diagnosis of this patient was the patient had 2 missense mutations, okay, on the trans chromosome, all right? So we talk a lot about precision medicine. So in G6PD deficiency, we know that, we can see that precision medicine is very important now, okay? And as a summary, the take-home message is that G6PD deficiency actually do not only affect the red blood cells, but other cells of the body, and manifestation may not be only acute hemolytic anemia. It may also affect or be associated with other conditions as well, all right? So that's why identification of this deficiency is very important. The other reason is the severity of hemolytic anemia also may vary, all right? So we have to investigate as much as possible, as specific as possible, right? Meanwhile, if we do not have all these facilities, we have to educate the patient, all right, as to safe and unsafe medication, which food to provide, and what kind of infection that the patient has to comply or be aware if they have episodes of hemolysis. With that, thank you very much again for your attention.
Thank you very much, Professor Naraza. Now time to Dr. Anggraini, please, 15 minutes for you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you. I'm honored to be here. Thank you for all professors, overseas delegates, students, and all participants here. This is the last session. Mudah-mudahan belum ngantuk ya. Jadi saya akan berinteraksi aja supaya nggak ngantuk. Outline of my speech is about overview of hematology molecular genetic, and then I have 5 cases. The question is, who needs hematology molecular genetic testing? There's someone who has family history of genetic hematology condition, like have G6PD deficiency or beta thalassemia, or someone who has increasing of developing genetic hematology condition, or have a symptom of genetic hematology condition, like anemia, thrombocytopenia, or another hematology manifestation. And then genetic hematology condition to your children, like if you have beta thalassemia or alpha thalassemia, so you develop and won't have children, and you have to check your children also. Someone who have pregnant and have reason to believe that your baby is a risk to having mutation of hematology condition. Application of hematology genetic testing is for inherited mutation, and then determine the somatic acquired abnormalities, for pharmacogenomic, and to gene studies of like hematology neoplasma in acute leukemia or chronic leukemia, and then identification about prognostic and determine the mutation in acute or chronic leukemia according to WHO classification, and to determine the minimal residual disease, and to determine the stem cell therapy. This is the hematopoietic stem cell hierarchy that we have to know before we go further. Stem cell in hematologic start from blast, and then the blast will be proliferate and differentiate into separate lineage, myeloid and lymphoid. And then the myeloid become the colony factor for the megakaryocyte lineage that become the thrombocyte, and then become the granulocyte like basophil, neutrophil, etc. And lymphoid lineage will become the lymphocyte B, T, and NK cell. Next. Potential hematologic molecular genetic testing that we can do in hematologic genomic testing. We can start from the cell. We can check the surface marker by flow cytometry or immunophenotyping, and then the protein synthesized by the cell or enzyme like G6PD, and then for chromosome analysis for karyotyping, and then in the DNA we can check DNA methylation, gene mutation, expression of the gene, and microRNA. This is very important. What is the flow of the molecular genetic testing in hematology? First, we have to start with hematology data first, and then we go further to the morphology by microscopic, manual, or digital morphology. And then we go further to the immunophenotyping by flow cytometry to determine who is this cell. Is this blast? What kind of blast? Lymphoblast or myeloblast? Or B cell or T cell by surface marker. And then we also can determine the cell subset by flow cytometry, cell proliferation, apoptosis, cell cycle, and then we go further to the cytogenetic. We determine number and structure. And genetic molecular by PCR or by NGS, targeted single gene or panel sequencing. Next. This is example of the landscape molecular genetic hematology neoplasma. I take the example from EML, acute myeloid leukemia. In the latest classification of WHO in 2022, now the classification already including the genetic abnormalities to make the classification of hematology neoplasm. In the fourth edition, there's no genetic classification to determine the diagnosis of acute or chronic leukemia. And the panel of the flowchart of the determine the diagnosis of leukemia start with the morphology, and then immunophenotyping, and then karyotyping, and molecular or genetic. This is some of many mutation that we can detect to determine the myeloid or lymphoid neoplasm. Next. This is the other example of lymphoid lineage. Next. Case number 1. This is essential thrombocytosis. 36 years old man with hypertension and Raynaud phenomenon with the platelet count 1,000,000.3, and then leukocyte also high, and then the morphology of peripheral blood, we found that there's so many giant platelet and some micromegakaryocyte on the peripheral blood. And I suspected these cases as the myeloid proliferative disease, and differential diagnosis with the essential thrombocytosis. And I suggest to check the JAK2 mutation and BCR-ABL mutation, and then evaluation for the bone marrow assessment. Next. This is the evaluation of bone marrow. This is so many beautiful abnormal megakaryocyte in bone marrow aspiration. Next. in flow cytometry, there's no specific mark, so it's getting confusing. And the JAK2 mutation, we found the mutation in V617F, and BCR-ABL negative. My question, why if we have to check BCR-ABL fusion gene in these cases? Who can answer? Raise your hand. Dr. Ikoma, bisa jawab? Kenapa mesti periksa BCR-ABL, dok? ET, kasus ET. Ada Dr. Nadia SPPD, apakah ada di sini? Bisa jawabkah, Dr. Ikoma? Next slide. Bisa, dok? Menyingkirkan? Menyingkirkan? Ya benar, Dr. Ikoma jawabnya benar. Jadi, in WHO classification, to determine the ET, essential thrombocytosis and polycythemia vera in the same lineage of myeloid. So, in CML, chronic myeloid leukemia, there's also in the same lineage. So, we have to exclude. So, in these cases, BCR-ABL is to exclude that the patient was not CML. Jadi, BCR-ABL to exclude the CML, and JAK2 to determine the essential thrombocytosis. According to the guidelines that in essential thrombocytosis, we have to check the JAK2 and then CAR, MPL. If the JAK2 negative, we continue to the CAR, and if this is also negative, we continue to the MPL. And this mutation also to determine the risk of the patient and therapy. Next slide. Cases number 2, 3-year-old boy with hemoglobin level around 7 and 8 with low MCV and MCH, ferritin normal. The electrophoresis shows that there's increasing of HbH2 and there's HbE. The conclusion is this patient have the thalassemia HbA. Next slide. DNA analysis to this patient shows that they have the mutation in codon 26. We do the sequencing with beta thalassemia panel. In codon 26, we have the changes of the GAG into AAG heterozygote. The problem is, back to, the problem is in HbE thalassemia, this is not matched to the Hb is not anemia. In HbA disease, the patient will not anemia. So the pediatrician think that there's another mutation that not covered by the DNA analysis. And we check the electrophoresis Hb in father and mother. The father have the HbA heterozygote because the HbA level increasing, and mother have the HbA2 increasing. This is thalassemia beta heterozygote. So, next slide. These children have the another beta thalassemia that not covered by this DNA analysis, and suggested to doing the whole genome for the beta thalassemia sequencing. Next. Cases number 3, acute myeloid leukemia, patient with blast in peripheral blood, 34%. There are so many blast cells, and the immunophenotyping, we do not found any specific marker. Next. We do the cytogenetic analysis, and we found there's deletion 7 and translocation of chromosome 8 and 21 and deletion of chromosome 18. Next. In WHO classification, already including the translocation of chromosome 8 and 18 and fusion gene of RUNX. So, and according to the prognostic score, this translocation is good prognosis. And this patient, after get the treatment, the patient get well, and the other cases of this patient is he has tuberculosis. Next slide. Cases number 4, congenital dyserythropoiesis anemia. This is 1.5 years old girls with hemoglobin level only 2. And the pediatrician asking for the bone marrow analysis, we found that in bone marrow hypercellular in erythroid progenitor. So this is there's a discrepancy of why in bone marrow there's many progenitor of erythroid, but in peripheral there's anemia. So next slide. We think that this patient should continuing to check the mutation in congenital dyserythropoiesis anemia, grading, to check another mutation. This mutation will make the proliferation of the erythropoietin progenitor stop in the middle. So the erythropoiesis cannot mature and cannot become to the mature red blood cell. Next. Last cases, myelodysplastic syndrome in childhood, 13 years old girl with pancytopenia, anemia, platelet low and leukocyte low. And in bone marrow analysis, we found very specific this granulopoiesis and this erythropoiesis. Next. And the cytogenetic analysis, we found the deletion of chromosome 5q deletion. According to the International Prognostic Scoring System IPSS for MDS, this patient have the grade 5q deletion is good karyotyping, but because the patient is a children, the prognostic become worse. Because in chromosome 5, we have several genes that regulate the proliferation and differentiation of the myeloid series. If the chromosome have deletion, means the gene cannot coding and produce this protein. This patient die maybe 6 months after diagnosis. Thank you. I think this is the last one. Next slide. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Anggraini. Now we come to the discussion, please. Okay. Questions to Prof. Zilvalil or Professor Nazara or Dr. Anggraini? Is there any questions? Okay, Prof.
Hello.
Yep.
Wanted to ask a little bit of a question about G6PD pathogenic variants. As a diagnostic lab, we do find a lot of patients with G6PD pathogenic variants when we do exome sequencing or whole genome sequencing. However, in most cases, in pediatric settings, many of the patient does not actually show symptoms of anemia, and many of these pathogenic findings are often considered part of an incidental finding, where we cannot report these variants to the physicians. However, as you have mentioned it during your talk, many of the G6PD pathogenic variant carriers can be medically actionable by avoiding certain substances before they are show up. So do you think G6PD should be included as a part of the secondary findings that are recommended by ACMG guidelines? Just wanted to know your opinion on it.
Very challenging and interesting question. Actually, as you know, I don't know whether I should stand up. Okay, 400 million people are affected globally, but it doesn't mean that these 400 million people are, all every day they have hemolysis. All right, so usually they are asymptomatic, but they are still prone to hemolysis. All right, even when they grow up. We have had cases where, a young man was exposed to infection, and then food, for example, all right? And suddenly he developed hemolysis. Whereas before that, he was noted to be deficient during neonatal screening, but he didn't have any episode of hemolysis, all right? So this hemolysis sometimes can be severe, and they may have to be given blood transfusion, all right? So, I would think that you cannot say that this is incidental. It is pathogenic, actually, all right? So that's my simple question to that. Okay, I hope that explains.
Yeah, thank you very much.
Thank you. Any more questions?
Can I add?
Okay, Prof. Sivalil, please.
Thank you. Yes, I would like to add to what Professor Naraza has said. I think that's a very good question. I think, in fact, this is a good example of a condition where it should be reported, because this is something which I'm sure every one of us would want to know if we have such a mutation. As Prof. Naraza mentioned, it's not every day that the patient will get hemolysis, but at any time that he or she can be exposed to any of the triggering factor, including drugs. There are drugs in which this XPD patient needs to avoid. So these are the drugs that they need to know, and they need to inform their doctors. So I think this is a good example of where a whole genome sequencing is important in order to prevent or to avoid situations like this from occurring in the future. We are talking about the future. So this, in fact, to me, this is a very good example, and I think this should be reported. Thank you.
Thank you.
Yeah, okay. Prof. Sivalil, this is the quiz for you. Could you explain a little bit about this results?
Okay.
Yeah.
A is false. I think I mentioned earlier, this is very obvious. I think the answer is autosomal recessive. And B, molecular testing, I think this is a bit controversial. So it depends. So 29% answered true, I think. That's true, right? It's true. So it can be true, it can be false. So depending again, you can argue about the answer. It can be true because, when you do molecular diagnosis, that's the, it's proof. that the patient carries the mutation and the patient has the disease. So it's true. However, in many countries, this is not being done. Molecular testing is not being done as a primary test, and most of the cases can be diagnosed by just using hematological test, a full blood picture followed by HB analysis. So it can be true, it can be false. So both answers are okay. So I would say that if this is an undergraduate, this is a test for undergraduate students. If the student answer false, I can accept that. But if this is a test for postgraduate students in hematology, perhaps I would not accept that answer. So C, thalassemia affects individual in malaria endemic area. I think this is true, as I mentioned in my lecture. So those two are very related, malaria and thalassemia, the evolution of thalassemia. And thalassemia is most common in high-income countries. This is false, because generally, primarily, it occurs in low and middle-income countries, as I explained earlier. But due to migration, it can also now higher-income countries have a lot of thalassemia and sickle cell disease. So because of migration, for example, in America, primarily there was no sickle cell disease or thalassemia, but due to migration from people from Africa and also from South Asia, now you see a lot of cases of sickle cell disease, thalassemia, not just in America, but also in Europe because of migration. And I think there's one more E. Can you go below? E, A, B, C, D, and E. Yes. So thalassemia is characterized by abnormal hemoglobin production. I think this is true. I think this is a straightforward answer. So the problem is with the abnormality in the production of hemoglobin, because it can be either in the alpha or the beta chain. And this is due to the mutation of the gene. So I think this is quite straightforward. There's another question by me. Okay, so diagnostic tool for thalassemia, karyotyping, I think this is false. You cannot identify by karyotyping the mutation in the beta globin gene or the alpha globin gene. So you have to do a molecular test. No karyotyping, so it's false. Fish also, I think, is false. I do not think there's any fish probe for the HBB gene or the alpha gene, as far as I'm aware, unless there is a probe, to detect, a deletion in the alpha gene. Then you can use fish, but generally no, it's false. And mom's PCR, yes, that's true. I think that's, as I mentioned in my lecture, that's the most common test. You are the primary test used in many countries, Malaysia, and I believe also maybe in Indonesia as well. Simple test, multiplex test. And full blood picture, yes, I think this is a primary test. It can be done in many hospitals in Malaysia, even the small clinic in the rural healthcare center, they can do a full blood count or full blood picture. And then capillary electrophoresis, I think this is true. This is without a molecular diagnosis, you are able to diagnose thalassemia by using a CE, especially for HBE. I think Dr. Iriani mentioned in Indonesia, you say it, HBE, HBE. So I think those are my questions. Yes. Thank you. Any question? I'm happy to answer. Prof. Sophia from Mubarak.
If there is some questions for Professor Zulfalil. Yep, please.
Thank you. My name is Nadia, a clinician. I have a question about the thalassemia. Actually, we found so many anemia cases in the practice, and several of them has note from the first line of health facility that mention about Menzer index and the officer mentioned that the Menser index below 13, so we supposed to test for the thalassemia.
Sorry, the Menser index.
Yeah.
Never heard. Have you heard?
Saya lupa rumusnya. Jawab dalam bahasa Indonesia aja. Izin jawab dalam bahasa Indonesia aja biar gampang. Saya pernah dengar sih Menser Index itu perhitungan antara apa ya dok ya? Lupa saya. Iya, saya pernah dapat itu.
MCV divide with RBC.
MCV dibagi MCH ya?
RBC.
Ya.
And what I want to ask is, in this time, how important the calculation of Menser index, that the indication that we need to follow up with the thalassemia test and diagnosis.
Izin jawab ya, dari pengalaman saya ya. Kalau saya sih di laboratorium itu jarang pakai measure index. Memang sih ada di jurnal disebutkan ya perhitungan itu, tapi kita tidak memakai itu. Jadi for screening thalassemia, we have to check HB level and then MCV, MCH. But be careful. In alpha thalassemia with 1 or 2 gene deletion, there's no anemia. Is it right? Yeah. No anemia, but MCV and MCH very low. Be careful. There's no anemia. Maybe justru HB level of the patient increase as the compensation of the bone marrow to increasing the RBC. In alpha thalassemia with 1 gene deletion, HB level of patient may be 16 gram per deciliter. If you see the discrepancy, HB level increase and MCV and MCH very low, I predict maybe 90% correct there's alpha thalassemia 1 or 2 gene deletion. Because 3 gene deletion become HBS disease and anemia. With anemia, MCV, MCH level, and HBA disease itu kita bisa lihat pakai pewarna retikulosit sih, ada itu ya. Jadi saya nggak pernah pakai, tadi itu apa? Measure index, saya nggak pernah pakai. Jadi lihat itu. Gitu. Dan pastikan ferritin level normal. Because if you check the HB electrophoresis HB analysis with the ferritin low, the fraction HBA will be a little bit low. And you confusing whether this is alpha thalassemia. So in my hospital, the panel of screening thalassemia must including hematology and then ferritin level and then morphology. Like I mentioned ya, the flow of the hematology analysis and then morphology, it is very important. Thank you.
Okay, thank you very much. Yeah, now the quiz for Professor.
We have 2 questions. Thank you. So we have 2 questions for G6P deficiency. All right. So the first one is sign and symptoms of G6P deficiency. Include, okay? Please check one or more. All right. There may be more than one options. Jaundice, yes. Okay. Right upper quadrant tenderness. The answer is true, all right? So anemia, tachycardia, weakness, yeah. So the straightforward answers are jaundice, anemia, of course, tachycardia, which may result from anemia, of course, weakness, very general symptom. We are also weak after, grueling workshop today, right? But the second answer, right upper quadrant tenderness, it may be a rare presentation, but may be associated with individuals with G6PD deficiency, especially those with chronic non-spherocytic hemolytic anemia. So now there's a group of patients, but very rare. They have G6PD deficiency, and they have chronic ongoing hemolysis. All right. So these are the patients that we may miss. We may, may want to do further investigation. So these patients, why do they have right upper quadrant tenderness? Is because of gallstones in the bladder, all right? Because of chronic hemolysis, the hemoglobin will be broken down and there's accumulation of gallstones. But luckily, the group of patients with chronic non-spherocytic hemolytic anemia due to G6PD deficiency is very rare, but has been reported, even in patients in Malaysia, all right? The second question, okay, tests to diagnose hemolysis in patients with G6PD deficiency. One is complete blood count, of course. They have nomocytic, nomochromic anemia usually. Ferritin level, no. All right, ferritin level you do when you suspect a patient with iron deficiency anemia. Fluorescence spot test, yes, is one of the screening method, as mentioned earlier. Next is LDH. Yeah, the LDH can be increased because of hemolysis, red blood cell rate breakdown, and reticulocyte count. During the acute phase of hemolysis, the reticulocyte count will be increased because the bone marrow has to compensate for the anemia. All right, is there any question? I think it's quite straightforward, right? Thank you.
Any more question? Last question? Maybe? Yeah. Okay. Oh, two. Okay.
Hello, doctor. I'm Fitra. I'm a student here. I want to ask about the post-test. I mean, like after maybe about the hematological molecular testing that may you do on your lab. So, is there any like a post-treatment test for the patient? Maybe, if I'm not wrong, you mentioned about minimal residual disease or minimal residual disease monitoring. Is it like you have been doing on your lab? And I want to ask about the methodology that you use. Is it like a genetic testing based, like you see the SNP and then you accumulate the SNP to see the number of like residue on that blood, maybe, I don't know. So can you elaborate more about the minimal residual monitoring itself? Thank you.
Terima kasih, Dok. Saya jawabnya pakai bahasa Indonesia aja biar gampang. Ya, jadi untuk terutama minimal residual disease itu pada keganasan hematologi untuk melihat apakah ada masih ada sel blast, biasanya untuk menghitung apakah masih ada sel blast setelah pasien menjalani sejumlah regimen kemoterapi. Yang biasanya dilakukan perhitungan minimal residual disease untuk menghitung sel blast adalah dengan pemeriksaan flow cytometry yang saat ini dilakukan. Jadi pada diagnosis pertama sebagai baseline, we count the blast count by morphology or by immunophenotyping. We get the percentage of the blast, and then patient get several treatment of chemotherapy. After that, we count the minimal residual disease to see whether there's still blast count. Bisa juga mungkin maybe dengan circulating tumor cell, tapi itu biasanya pada solid tumor ya, Prof. Bener. Kalau di hematologi itu biasanya pakai flow. Tapi kalau circulating tumor cell bisa juga pakai flow cytometry. Ada beberapa tapi masih Di Darmai sih masih dalam riset ya, nasofaring, terus beberapa kanker paru itu sudah pakai flow cytometry juga karena ada panel khusus untuk CTC untuk panel-panel tertentu yang sudah established gitu, tapi masih dalam tahap riset sepertinya, Dok. Demikian.
Makasih, Dok.
Okay. Thank you. My name is Dr. Christo from Inharmony, Jakarta. So Prof. Zilvalin and Prof. Naraza previously have just given some examples of some diseases, newborn diseases, that might be impending, might be asymptomatic, but might have more symptoms later in life, maybe like G6PD or thalassemia. Yeah. So what I want to ask is whether we should do newborn screening and what kind of tests do we need to do? What should we test for newborns, for newborn screening, and what can be done with molecular tests for newborn screening? Thank you.
Thank you very much. I think that's an excellent, very excellent question. In fact, I like that question very much. I wanted to put in my slide. My last slide normally, but I thought that it's not proper, and I think our friends from 3 billion would also love me for saying this. But what I want to say is the future is in genomic screening. So as a geneticist, I strongly believe that we should do genomic screening for everyone. So also in most of my lecture, in my last slide, I usually I will write genomics for all, leaving no one behind. So we need to do, all of us, we need to do a genomic screening for ourselves so that we can determine our future. We can at least predict what our future. Of course, the final decision what will happen to us in the future is from God, from Allah. But from our DNA, we will be able to gather, a lot of information what is going to happen to us in the future, especially for diseases. And I think as doctors, any healthcare personnel would want to know this, and we want to prevent this from happening. So I think that's the future. That's the way forward. We have seen Genomics England. They have started a pilot program a few months back. To screen newborn, to do newborn genomic screening for newborn. So, of course, there will be a lot of challenges, for this pilot project. The outcome may be favorable, may not be favorable, but I think they have already shown that, at least there is, they're willing to try out whether this is the way forward by screening our newborn. If we know, if our newborn know their DNA, their genomics profile, I'm sure in the future we will have gathered more information about what will happen, to them, to any mutation or any variants that we see in our genome. Someone mentioned about VUS. Of course, there are many VUS now, but remember, today it may be a VUS, next week it may be pathogenic, or it may be benign. So things are evolving, and they are evolving as we speak in real time. And I think we will see a lot of improvement in genomics. And that will be a time where I think genomic screening will be routine. So I strongly believe our newborn deserve to have a genomic profile. So genomics is the way forward. So, if screening, we are now doing newborn screening, but we are not doing genomic screening. We are doing, targeted testing, diseases which are common to the population, diseases which can be, which have treatment. So all these criteria, mainly because it's expensive to do genomic screening, but, if we have the means, why not? Do just genomic screening, and just learn and have the information, have a genomics profile. And someone asked me, how will you store, the large data that are generated from your genome profile? So I think we should discuss of ways, in storing the data. Someone mentioned in Malaysia, we have identity card, we have a chip in our identity card. And even now, as we drive a car, we need to pay the toll. We can pay in Malaysia. You can use your identity card, and top up with some money. You can pay using your identity card. So why not store our genomics profile in our identity card? So that's one of something that which we can think about. So as a geneticist, I strongly believe in genomic screening. And yes, you are free to say that you do not agree with me.
No. No, it's not that I'm not agree. I think that by what you said, is that not only newborn, but even us have to do the screening. Maybe we still have some disease that we have never encountered before in our life.
Yeah, some diseases appear much later in life. Old Alzheimer's, for example. So why not? If you have the means, why not you do a genomic profile and look, for any of these variants. Yeah. So I can see the 3 billion guys are agreeing with me.
Thank you, Professor. Naraza would like to. One more question. Okay. Okay. Should we stop or just we leave it? Oh.
Thank you for the opportunity. My name is Vanessa. I have a question for Prof. Alwi. How's the regulation in Malaysia in controlling thalassemia? As we know, some country, they have some regulation like before a couple get married, they have to test for thalassemia. And if both of them don't have or didn't carry any trait, so they can get married. Because in Indonesia, I think we still it's still hard to detect thalassemia in couples. Thank you.
This is again a very great question. Thank you so much. So back to the same question that was asked earlier about newborn genomic screening. So if we can do a genomic screening for our newborn, we will be able to tell whether that baby will develop thalassemia or not, or whether that baby will be a thalassemia carrier or not. So based on that, if we have a genome profile, all of us, if we have a genome profile, we will be able to identify whether you are a carrier or not, whether your future husband is a carrier or not. So the key is still in having a newborn genomic screening, a genomics profile for the newborn. You can also, from there you can detect whether that baby or that individual is a carrier for thalassemia or not. In Malaysia, couples who are getting married, they are encouraged to do thalassemia screening. HIV screening is compulsory for any couples getting married in Malaysia. But thalassemia screening, they are just being encouraged. And I think the government, there has been recommendation to make all married couples getting married to undergo thalassemia screening, but the government has decided not to make it mandatory. So I am not aware. I'm not sure what is the reason, what is the decision. However, the government have decided. There's three times, basically three age group which you can screen: premarital, and also newborn, and also what the government has decided is to screen the secondary school students, 16-year-old secondary school students, for thalassemia. So the screening program has started in 2016. So that's about 8 years ago. And already, I think more than 1 million Malaysian secondary school students have been screened for thalassemia. So there are, but again, this is not compulsory. The team of nurses will go to the school, all the schools, to screen. But the parents, they have a right to refuse the screening. So even though the screening is not 100%, but most of the students have been screened. and many carriers have been identified. And I think these are the students who are going to leave school at the age of 18 years, and they may get married when they leave. They may start working and they may get married. So it's almost, you can say as like a premarital screening. And I think it's acceptable, it has been accepted by the Malaysian community, the public. But still, if you ask me, newborn screening is the way forward. Yeah.
Okay. Thank you so much.
Yeah, it seems still so many questions will be arise. According to the committee, because this topic is so interesting, so I would like to open one more discussion. So please raise your hand if there is some questions still. Okay, one, another questions? Yeah.
Thank you. My name is Noreen, and I would like to ask question to Prof. Silvalil. Prof, how about the ethical aspect in the genomic newborn screening? When will we deliver the information to the parents maybe, or do we need to wait the baby until get some get adolescence or maybe adulty? How is your opinion about this?
Okay, thank you again. This is a great question. Now I know why Prof. Sultana likes you very much. She said you are her best student. So only good students, best students, they ask good questions like this. To be honest, I do not have an answer. So I think this is one of the biggest challenge in doing a newborn genomic screening. And I think this issue has also been acknowledged by Genomics England. So when they started the pilot project for the genomics newborn screening, this was among the major issues that they say that they will face. And we are hoping that as a result of the pilot project, we would be able to have some answers or some recommendations to address those issues. So like I said, to be honest, I do not have an answer for that. We can continue discussing, but as mentioned by Dr. Ahmad, we may not just Maghrib, we will not finish by Maghrib, maybe by Isha as well. So it's a good issue, but I do not have an exact answer, and I do not think that there is a one single right answer as well. Yeah.
Yeah. I wonder with this the last one. Masih ada pertanyaan? Any questions? Okay, from the Philippines, Dr. Lin.
I have a question. I just want to share. For both questions, people who asked about newborn screening. In the Philippines, we do newborn screening for G6PD and also for thalassemia, and we also do the molecular testing for thalassemia. So for your question about when we inform the families, as soon as the results are there, we already inform the families of the actual diagnosis or the actual molecular result. For the G6PD, we do newborn screening. Actually, it's very common. It's 1 in 62 babies or individuals that are found to be positive. We don't do the molecular testing for G6PD because it's very expensive. However, what we do is we inform them of what to avoid. There are certain drugs, certain foods, certain medicines or whatnot that they have to avoid, and these are already informed immediately as soon as the results are out. That way, they can already tell their doctors that my child has G6PD, and maybe you need to avoid certain medicines when they get admitted to the hospital. So for the For the thalassemia part, this now will help in the management as soon as the molecular results are there. And it will help also, well, hopefully later on when they get married. I know that carrier screening is the thrust now for avoidance for decreasing the incidence of thalassemia. However, we still are not yet there. We still do not have, policies or guidelines for screening or getting married. When you get married, you do the counseling. We still are not yet there. That's why we still have a lot of things to do for thalassemia. But then for the results, it will help the hematologists manage the patients.
Okay, please, Doctor.
Thank you. So I want to continue this discussion up to the ethical and legal perspective. Yeah. So I heard in developing countries like US or Australia that people doing genetic testing, like you said, we can screen ourselves. Then when we get the results, it is connected to health system, that the insurance won't pay you if you get the disease that is existed in your genetic as part of genetic disease. So first question would be, what about in Malaysia? Just for sharing, maybe if you have information about it. And the second and maybe the hardest question would be, what do you think about it? Because I think it's not fair. It's for, maybe in Indonesia we can do screening because it's not connected yet. So I told my patient, if you got this disease, then you better buy insurance before it happened, right? but if it is connected to the health system, then it's not fair. You know that you have that risk, and the insurance won't pay you. It just doesn't seem fair. Thank you.
Okay, again, very good question. So 2 weeks ago, WHO, I'm a member of the WHO. They have formed last year. They have formed what they call the Technical Advisory Group on Genomics, the TACG. So this is following COVID pandemic, where during the COVID pandemic, they noticed that many countries do not even have a proper genomics or genetics facilities or a capacity to diagnose, to do the profiling of the virus, the COVID virus. So there's a big, huge gap between the high-income countries where they have, the cutting-edge genomics lab, and the low-income countries which doesn't even have a genetics lab which can do a PCR for the COVID virus. So because of this, WHO has identified genomic as a very important area for healthcare for the world. And the aim is to narrow the gap between the higher income country and the low income country. So one of the issues that we discussed 2 weeks ago when we had a meeting was how to tackle this issue. The ethical issue as well as the insurance issue. So by doing a genomic profiling, we know that there are a lot of advantages, especially in healthcare and disease prevention. But the pitfall is to get insurance, as you mentioned. So there is no answer at the moment. There must be a discussion on how to go around this issue with the people, the stakeholders, the government, the policymaker, as well as the companies, the insurance companies. There should be some guidelines, in fact, legislation in place before we can safely say that all the interests of everyone is taken care of. Everyone, including us, the patients, the public, the community. So without any legislation in place, you are right. This patient will be at a disadvantage, and they will not agree to do genomic testing. So that is sad because it will be a step backwards in terms of healthcare. So the progress must be in line, as you mentioned, with legislation safeguarding the interests of patients as well as the community, the public. So at the moment, you're right. Even in Malaysia, we do not have any legislation. I think it's still a big issue. But I think it is not easy, because everybody has their own interests, especially, those insurance companies. They will also try to safeguard their interests. But I'm sure as genomics is becoming more routine, it will be in the mainstream practice for medicine. Then I think whether they like it or not, they have to, to adjust themselves, to fit in the progress. So the government needs to play a big role as well. The government of the country, the policy makers. So I don't know whether I've given a good answer.
Thank you so much. Please give applause for the great speakers. Also, a big applause for the great participation. I give it back to the MC.
Okay, thank you, Prof. Sofia Mbarika. And next we will have certificate presentation and group photo for all the speakers from 3 billion, Dr. Sung Wuri, yeah. And then we'll also call Pak Ahmad and Prof. Rika, also the speakers from the last session, Prof. Zilfalil, and then Professor Naraza Muhammad Yusuf, and Dr. Anggraini. I invite you to the front of the stage for certificate presentation by Professor Sultana Faradz. We would also like to remind everybody to stay in your seat because we will announce 3 best participants for this workshop. Let's give a round of applause for our speakers. And next, I would like to invite Pak Ahmad to give a closing speech. And also announce the 3 best participants from this workshop. Okay, so we're still waiting for the 3 best participants' names.
Bismillahirrahmanirrahim. So all good things apparently have to got to the end. We wish we can go proceed until subuh maybe, but apparently that's not possible. First of all, we'd like to thank all of you, to thank all the participants in this first day of the workshop and symposium series. It's been done. It's quite interesting, yeah. The topics and the last one, it seems everybody's very engaged, and we appreciate. So we would like to congratulate all of you, all the participants, to get involved in how to, understand the complexity of this disease, genetics, the counseling, and also the testing. So this time for us to actually announce the top 3 best participants when they can actually respond to the question. Okay, so I guess I'll start with the 3rd place is Mega Hayati from Universitas Yarsi. Okay, stay first. We'll call you together. Okay. And then the 2nd place is Dr. Tiar M. Pratamawati, Biomed from Universitas Gunung Jati. And the last one, and not the last one, the 1st place. Okay, ready? From Universitas Pertahanan, Dr. Venti Mulyanasari. Okay, for all these 3 winners, please come to the front to receive our appreciation from Prof. Sultana.
We invite the 3 best participants to come to the stage.
And we would like also to thank all the committees, all the team, the technical committee members for having this arrangement. We still have next couple days for having this possible. Prof. Sultana, please.
The first winner will receive a voucher from Prodia. And the 2nd and 3rd place will also receive a gift from the organizing committee.
Yeah, congratulations to everybody. So this is the last moment, we're going to see you, inshallah. Hopefully, all of you also register for tomorrow, symposium, a couple of days. It's going to be exciting lectures and also discussion. Don't miss it. And as we say in Indonesia, we say Hamdallah, Alhamdulillahi Rabbil Alamin. I'll see you all again tomorrow. Assalamualaikum warahmatullahi wabarakatuh. Have a good evening.
Of today, and we hope to see you tomorrow at 8. The registration will start and the symposium will start at 9. For all the speakers, we'd like to inform you that there will be an early dinner at the hotel for all the speakers.